So we weren't sure how this was going to turn out, but we have a lot of intrepid DC people who care about health policy here. It's wonderful. I'm from Minnesota, so I usually would be making a lot of jokes right now, but instead I'm just very impressed. You guys really braved the weather. We really appreciate it. So welcome, everybody. We have had quite a year for health policy. Oh my goodness. Between HR 1 and this fall's ACA discussion, people in this room have been very busy. And we saw some progress on savings, right? We had some, some bright spots this year. CMS made some changes to the physician fee schedule and to Medicare Advantage coding intensity methodology, super weedy, but very important. We saw some important changes to Medicaid provider taxes and supplemental payments. But we know that we have a long way to go. Rising healthcare costs are putting pressure on American budgets, both the federal government and for families. Healthcare continues to make up a quarter of federal spending annually and is set to continue to grow. This includes about $1 trillion for Medicare. $1 trillion, like we're gonna hear the word trillion a lot today, which is kind of crazy. There's over $800 billion in spending annually for Medicaid, the Affordable Care Act, and other related spending. According to the Congressional Budget Office, spending on major healthcare programs has made up a little over 4% of GDP over the last 30 years or so, kind of hovering around 4%. But we're projected to rise to 7% of GDP in 2035, and that's not including commercial spending. When you add in commercial spending, we're up to 18% of GDP. We know that this is unsustainable. So during the fall, Congress and stakeholders debated extending ACA enhanced subsidies, which would be a cost of $350 billion over 10 years. To our dismay at the committee, talk about offsets was not very robust. With the national debt at $30 trillion, we have to take responsibility for our choices. And that means not making things worse. And there are so many smart ways to offset our priorities. I bet every single person in this room has a favorite offset. I know Kim does, Josh. Everybody has a favorite offset, and we can all work together. We can definitely make this happen. The cost of commercial insurance continues to rise. Recently, I think the studies are saying that volume and intensity is kind of fighting with prices to be the main driver of increased costs for commercial insurance. But what we know for sure is that these year-over-year increases are really just maintaining the status quo. They're not necessarily making people healthier over time, and they're not really improving the economy. And any way you cut it, dollars spent on employer-sponsored insurance premiums are dollars that are not generating federal tax revenue. We need to reduce the cost of commercial health insurance so we can increase wages and tax revenues. Another important topic is Medicare Hospital Insurance Trust Fund. The trust fund is scheduled to run out of money in 2032, which is in 6 years, which is, getting a little bit scary. Without changes, that means that Medicare providers will face a cut of 12%. And we've heard a lot of people say, Congress will never let that happen. But a lot of weird things have been happening lately. And to not let it happen means making some really hard choices. So with those challenges ahead of us, we are so pleased to hear from both policymakers and renowned health policy experts from across DC to help us think about ways to ensure Medicare solvency and reduce the cost of healthcare. To get us started, I have the great honor of introducing our first keynote speaker. Kim Brandt is the Deputy Administrator of the Centers for Medicare and Medicaid Services and Chief Operating Officer. Kim has served the vast majority of her career in the federal government at HHS OIG, at CMS, and at the Senate Finance Committee. This is Kim's second stint helping to lead CMS, as she did so under the first Trump administration. Kim currently leads CMS's work on program integrity, operations. She oversees CMS's 6,000 employees and its $1 trillion budget, which affects 170 million Americans. And if you know Kim like I do, you know she is committed to integrity and public service. Kim has visited 79 countries. She learned to drive a tractor at age 5, and she is famous throughout DC public policy circles for amazing chocolate chip cookies. Please welcome Kim Brandt.
Sadly, I did not have time to bake, so sorry for those who are expecting the chocolate chip cookies. I was just happy to get dug out so that I could get here. But anyway, well, I'm very honored to be here today, and it's thank you to Anna and everyone for having me. I have 20 minutes to give you an overview of what's happening at CMS, and there is nothing going on there. So I don't even know where to start, really. But I'm going to start by kind of organizing it a little bit around our OKRs, our objectives and key results. Dr. Oz is a huge believer in these, and we sort of organize all of our work at CMS along those lines. So I'm going to focus on a couple of them because we only have 20 minutes today. But the ones that I want to focus on are the first, which is for CMS to be a leading payer. And Anna alluded to this already with some of the fun stats that she gave out in the opening. But CMS is a leading payer in that we are the world's largest payer. Our current budget, as Anna pointed out, is $1.76 trillion. We cover 170 million covered lives across Medicare and Medicaid in the marketplace. And fun factoid for the next time you're playing trivia with your friends, if CMS was a country, we would have the 16th largest GDP in the world, right between Australia and Turkey. So just throw that out there to next cocktail party you're at. Well, did you know? Anyway, but the result is that we are extremely busy at CMS, and we get busier every day because every day 10,000 new beneficiaries age on to Medicare. And so that continues to grow our base. In addition, as Anna pointed out, the Medicaid spending has continued to expand as well, particularly with the passage of the One Big Beautiful Bill last fall. We're so excited about what's been happening with the Rural Health Transformation grants and what we're doing there. We just gave out the first round of awards for them. I think you can also expect an announcement in the very near future on community engagement and some big steps on that as well. And so we continue to sort of stay very busy in terms of setting the stage for that. And one of the ways that we really want to make sure that we're a leading payer is aligning a couple of the other objectives and key results, which are to empower beneficiaries by giving beneficiaries more tools to be able to manage their Medicare and the other programs they participate in, and to incentivize providers. So I want to talk a little bit about that because that kind of ties into what we're calling the health tech ecosystem. For those who haven't heard about this, CMS is trying to get into potentially the 20th century, if not the 21st century, technology-wise. For those who are not aware, we still code in COBOL at CMS. There are no people that learn COBOL today. It's very hard to find people to know COBOL. And so as a result, that makes it very challenging because every day we pay out 4.5 to 5 million claims worth over $1 billion using COBOL. So we need to get this fixed. All of our MACs, our Medicare Administrative Contractors, run off of that. It's a big part of our whole claims system, but we need to get that updated. We need to update our technologies across the board to allow us to not only be able to pay the providers that are providing the services to our beneficiaries, but to ensure us that our beneficiaries have the most accurate and up-to-date information to know about the services that they're receiving. So we have a number of things underway under the health tech ecosystem that I want to touch on. And then I'm going to spend the second half of my remarks talking about the stuff that I care most deeply about, which is crushing fraud, which is one of our other OKRs, and some of the work that we're doing in that, which is particularly relevant to extending the life of the trust fund, hopefully, if we're doing our job right. So let me start, though, by talking about what's happening with the health tech ecosystem. We have many moving parts with that. The first part is that we are trying to make all of the data that we can on the patient and claim side more interoperable. In an ideal world, Dr. Oz wants to have it so that every Medicare beneficiary would be able to choose from a series of apps off of their smartphone, which would allow them to get get their claims information, meaning they could see what claims have been submitted in their explanation of benefits, instead of getting that on a quarterly or, however much basis you get it. We just reduced it to 3 times a year, so I guess not quite quarterly basis, but instead of getting it 3 times a year, you would be able to look in real time. You can do that now on Medicare.gov, but in an ideal world, you get it on your phone. In an ideal world, when a claim is submitted on your behalf, you would get a ping on your phone that would say, hey, Anna, we noticed that you just had a service from Dr. Brandt. Did you see Dr. Brandt? Yes or no? And you could respond, yes or no, and then we would be able to know if that's a legit service or not. Then the claims information could be cross-referenced with your clinical information. If you allow it, again, this is all at the patient's choice, this is not mandated, but if you allow it, it would take your clinical information and be able to say, hey, you know what? Based on your wearable information, your smartwatch or whatever, I've noticed that your continuous glucose monitor has said that your A1C has been consistently high for the past couple of months. I also noticed in your claims history you haven't been to the endocrinologist in over 18 months. Here is a list of 6 endocrinologists within 20 miles of your current zip code where you could go and make an appointment. In Dr. Oz's ideal world, it would be like ZocDoc, where it would actually make the appointment for you. I'm not sure we're going to get quite that far quite yet, but in an ideal world, hopefully within the next couple of years, that's where we're going to get, so that you can have it, so that your phone and the apps on the phone will actually help that Medicare beneficiary manage their Medicare experience by being able to have all of that come together. And then while you're waiting on that appointment that you're going to get with the endocrinologist, that hopefully it's going to help you set up, it'll give you a list of 6 or 7 things that you can do on your own to help manage your blood sugar, like drink more water, take more walks after meals, other types of things that can help you manage it in the meantime. So it's now not just us paying your claim and being a payer, it's Medicare being your partner in your health and really helping it so that Medicare beneficiaries have the support of a larger network to be able to help them manage their conditions. As most of you know, the bulk of the spending for someone is in the last 12 months of their life. That's where almost all of the Medicare spending comes down. For us, it's really that last 6 months where it really kicks up, but the last 12 months of life is usually where we see the biggest amount of spending. To the extent that we can help people prolong or manage comorbidities, things like diabetes, heart conditions, things like that, weight issues, et cetera, to be able to manage those so that they have less of those comorbidities earlier on, and to be able to help them so that they can hopefully have a longer, fuller life, that's a win all around, because it's helping not only from a fiscal perspective, because there's less costs if you can help manage it better, but also it's helping from a personal perspective. Similarly, we want to incentivize providers, another objective, by helping them get better information through all the data that we can collect. CMS every day collects a gazillion different data points through all the quality measures and all the different things that we require, meaningful measures, all of these different programs, all great, but it's a ton of data and it sort of goes into a black box. And so the idea is that through part of what's going to happen through the health tech ecosystem, eventually we can have it so that that data can be arrayed and provided to providers in a much more meaningful way to help them make data-driven decisions about healthcare, so that when they are looking at a patient and determining what course of treatment they are going to make for that patient, they can actually take a look at CMS's website and look at the different types of clinical options they have and be able to see the data behind it to help them better understand what it is that is going to be most effective for that particular patient. They're still going to need to be able to think through it because there's unique things with each patient, but if it helps them to make a better decision in terms of this has been proven to be the most clinically effective and cost-effective care, then that's a huge win as well, because the goal of this is to align spending and value, another objective, so that we can hopefully get it to the point where people are making smarter choices about what kind of care they're providing and make it so that that care is as cost-effective as possible. So in an ideal world, if you have it now that as the leading payer, we are helping empower beneficiaries to better work with us to make sure that they have more meaningful information to help them be able to know how to manage their conditions and hopefully have better choices about those as they go through, but also work with the providers to help them to have better data and better information to help them make more clinically effective choices, which hopefully also would be more cost effective. Then it's a win-win all around because it allows us to sort of put all that together and make it so that we have more efficient claims, we have more efficient outcomes, and we hopefully have a better way of making sure that people get better care overall. To do that, we have a number of things that we need to fix. The first is the COBOL problem I mentioned. Our claims are still based on this old system, and we need to figure out how to fix that. So to that end, we are pursuing a real-time claims option, if you will. As many of you have heard talked about, I think at some of the different events around town, we're doing this attempt to see if we can't have it so that we can, to the extent we can, pay more in real time. We're never going to get point of service like you do for a credit card. And if one more person comes to me and said, why can't you just stop fraud like they do with credit cards? I'm like, that would be great. Why didn't I think of that? But the reason we can't do that is because you have up to a year to submit a claim to Medicare after you provide it. And so it's not point of service. It's not like when you go to Best Buy and buy a large flat screen TV and it says to me, hey, Kim Brandt, we denied this claim because you don't normally drop $2,000 on, Best Buy purchases. It doesn't do that in Medicare because it can't tell you in real time that claim looks out of whack. Our goal, though, is with this real-time claims processing and with some of the fraud stuff that I'll talk about in a minute, we can get to the point where we can hopefully make it so that we can see those decisions and use that text capability that I was talking about with the Benny to say, hey, did you receive this service or not? To use all of those things to help us better understand whether or not that claim was actually provided, and do so within hopefully days, if not hours, of when it was provided. And that'll help us because it also helps the payers because then they get paid more quickly. We still have statutory constraints. We're going to need to work, obviously, with Congress. There's the 14-day payment floor. There are statutory constraints around all that. But if we can get to the point where we could even pay closer to and have information more real-time to that 14-day payment window and keep it within, say, a 30-day window, that would be a huge step forward for us on the fraud and abuse perspective, because then you wouldn't have those large gaps between when it is that a service is provided and when it actually gets processed through the system. And if we have a more agile, cloud-based, real-time way of doing that, it allows us to use, on the fraud and abuse side, better analytics, better AI tools, and other things to be able to see in real time when those spikes and aberrancies are occurring. The other thing that we're working on that I think is really exciting on the health tech ecosystem part of it is that we are also looking to create a national provider directory. This is something that is long overdue. There's lots of provider directories out there, but they all suck, sorry. They're just not very complete, they're not very good, and certainly the ones that we have at CMS are not as good as they should be. The goal here is to create a national provider directory, which we have a prototype already up and running. If people are interested, we can get you the website for that. But we have a prototype up and running of what this will look like, but ultimately it would include provider information for not only all of the Medicare enrolled providers, but also all of the people who have NPIs, National Provider Identifiers, and all commercial payers. In my ideal world, if I were queen for the day, I wanted to include Medicaid at some point too, because we don't have any place right now that integrates Medicare, Medicaid, and commercial provider data all in one place. So that way you can go to one stop, if you will, and be able to look up provider Anna Bonelli and to be able to tell who Anna takes in terms of insurance, what her practice location is, what Anna's practice specialties are, and other current information about her. Right now, the provider information that we have is inconsistent at best. We are required to revalidate providers on a 3 or 5 year cycle, depending on that, and that's 3 to 5 years where we can have huge gaps. Things change. I can point out to you, we just visited Los Angeles. If you haven't looked on Dr. Oz's social, by the way, start following his social. It's like cops real time right now. He's been out doing a lot of fraud visits and everything, which has been great because we've been really highlighting a lot of this. But literally, we went to a four-block area in California where there were 42 different hospices listed in that 4-block area. And I can guarantee you that the provider information on all of those was incorrect. And so the fact fact of the matter is we need to get it so that when, people go out of business, when they buy or sell businesses, when other things happen, that we are able to get that updated. That helps us from a fraud and abuse perspective, but it also helps in terms of providers knowing who are legitimate providers that they're having orders and referrals from and things like that. One of the biggest problems we saw with skin substitutes was that we had ordering physicians, the physicians who actually said, oh yes, I have provided, this skin substitute to this person, but then we had rendering physicians, which were sort of the ordering physicians or the referral physicians. We did letters to 192 of those. We had a 10% hit rate of people who said, I have no idea what a skin sub even is. I've never heard of this. So we had 10% of those providers, just in a small 192 provider sample, who were like, we don't even, we sent a letter saying, did you know that you've had these services billed? And they came back and were like, I have no idea. I have no idea what that is. I've never heard of it. Their number had been compromised and it was being used on their behalf. So the more that we can get to the bottom of that and have good, up-to-date provider information, not only does it help in the provider community, because that way providers know that they have accurate information on the people that they order and refer to, but it helps beneficiaries because they know that those are hopefully legitimate providers as well. So in an ideal world, what we will have is all of the National Provider Directory information will get run on a constant loop, if you will, to get cross-referenced with the Social Security Master Death File, with IRS records, with other records, to be able to help us to know, are these legitimate people or not, and what is the most current address and other information on them. And that's really important to us because that helps us with our, overall management of the providers, but also helps it so that then you hopefully won't have as many network adequacy issues because you'll be able to tell more realistically who's providing services and where, and it's just going to be helpful across the board on a number of fronts to ensuring that the program runs much more effectively. So let me switch now and talk about the last of the OKRs I haven't touched on, and the one where I want to spend the most time, largely because it's where I've spent a lot of my time lately, but also because it has an impact on everything I just mentioned, and that's crushing fraud. As I was talking about, this has been an area where Dr. Oz has taken a very hands-on, a very go big or go home approach. He is absolutely 100% committed to starting to figure out how it is that we can tackle fraud and abuse in the Medicare and Medicaid programs, but I'm going to stick to Medicare for today's purposes, in as wholesome and holistic way as possible. So let me start at the beginning with provider enrollment. One of the things that we have been looking at is what are our authorities that we can use to make sure that we are better able to determine that we're doing business with the people we want to do business with. As most of you know, when people apply for Medicare through the PACOS, the Provider Enrollment Chain Operating System, they have to fill out a number of things. They go through their background checks. They may have to go through an accrediting organization if they're a DME supplier. But once they get through all that, then again, there's no check that really occurs for the next 3 to 5 years. Maybe a occasional sporadic check, like as a site visit or something, but there really isn't a lot of continual oversight of them. We're looking to change that. We've been doing what we call a provisional period of enhanced oversight, where we've been looking, using our data analytics of claims data, at where it is that we think we have the highest vulnerabilities in the program. We always know that Miami-Dade County, sorry for anybody from Miami-Dade, is going to be a problem. It's just, we just know that that's always going to be a problem. We also know that certain hot spots in California, Texas, New York, Chicago, it's a very predictable pattern that we know. But what we don't know is where there's those other pop-up areas. I call it whack-a-mole. We shut them down in one area and then they go elsewhere. For instance, right now, the shady hospice people in Los Angeles are starting to migrate to Clark County, Las Vegas, and they're going to Nevada. So we're trying to track them. So what we're doing is, as we go and enroll or try to see whether or not we want to enroll this hospice supplier, we're now running them through an algorithm, which is really cool. It's like a Netflix type algorithm. And like on Netflix, it'll say, Dear Kim, you really like movies about traveling abroad and quitting your job. Here's a bunch of other ones that, talk about this. Well, in this instance, we fed all the information of all the people that we have revoked or taken administrative actions against into this database, and then we run all new people against it. So the fact is that enables us to really be able to hopefully be able to stop those people in real time. Oh, apparently I'm a little over, so give me 2 more minutes to wrap up. Sorry about that. Anyway, but the fact is that enables us to stop that on the front end. We also have done all new algorithms and advanced analytics to help us to be able to do that with the claims data in the same way, so that we can actually see in real time where we have spikes. One of the things that we've been able to see as a result of that is when stuff like skin substitutes, genetic testing, or other thing all come together, we're able to then go ahead and start suspending payments or stopping actions against providers who we think are defrauding the program. As a result of that effort, we stopped $2 billion just in the past year using these new advanced analytics and helping us to really then go from what has been the pay and chase model to the stop and cop model. So to wrap it all up, because I apologize, I thought I had 3 minutes left, but I looked at my clock wrong. To wrap it all up, to kind of say, I think what you can say from the overall Medicare perspective is we are changing how we approach every aspect of the program. We're looking at what impacts beneficiaries, what impacts providers, what impacts how we pay, and then how can we get more innovative, agile, and much more creative in how it is that we can help protect the program to hopefully keep it so that, while our spend may continue to go up, hopefully the dollars lost or the dollars that go out the door out of that is much smaller, and we can continue to push that trust fund solvency rate out as much as possible. So with that, I will end. Thank you.
Good afternoon, everyone. I'm Marc Goldwein. I'm the Senior Vice President and Senior Policy Director here at the Committee for Responsible Federal Budget. Wow, we have an amazing crowd. I really can't believe how many people came. I texted my wife a picture, and she said, people must be really sick of their kids. But I did see someone coming in snowshoes, and so I appreciate the dedication. What I want to do really quick is introduce someone that I think maybe sees this more as mid-spring. Or stick season, is that what you call it? Because stick season, yeah, no big deal out there. Senator Welch, the senator from Vermont. Senator Welch has a long, distinguished career in public service, in the state Senate, in the House of Representatives. Since 2023, as a U.S. Senator representing Vermont, he's been a leader on bipartisan issues, especially lowering health care costs, and really in convincing the left of the importance of fiscal responsibility, which we appreciate so much. So please join me in welcoming Senator Peter Welch.
It is pretty amusing to be a Vermonter and come down here and see the extraordinary skill of the snow moving operation here in D.C. I was home and it was snowing. It was so wonderful, because it was like 2 days of snow days, and my wife and I are there. I can't get out. She can't go. And we got the fire going. The snow was coming down for 2 days. It was incredibly cold. It was this fluffy stuff, where I shoveled 3 times and barely broke a sweat. Everyone's out skiing. And I come down here on the way over. We're driving over, and I didn't think we'd make it. I mean, the way people plow around here is like, these people have never seen snow and have never seen a plow, and it's on the front of their, SUV or something. I mean, they don't have real legitimate plow trucks. They go down the road and do a lane. This is a true story. Somebody just told me. They did a pass, got to the end of the street and turned around, and instead of then having the pass widen, they went down where it was already plowed and did nothing. So it's sort of like the strategy of waiting for it to melt. And so I'm just gloating about how much we enjoyed this snowstorm in Vermont. I am such a fan of Maya McGinnis and this organization, because it asks a fundamental question. We all know you can't, at the end of the day, somehow, some way, you got to pay your bills. And so much of the debate over the years in Congress is get frozen on the Democratic orientation, where we want to have more of a strong social safety net. I'm very proud that we do. And the answer is usually addition. And the Republican orientation oftentimes As lower taxes, they're going to pay for themselves, so it's a kind of subtraction thing. And most of us, and we're seeing what's happening with the income distribution and income inequality. So that approach just doesn't address it. And obviously, at the end of the day, you have to have a kind of balance of both. But what that discussion just totally disregards is we need some structural reforms. And, you know, healthcare is an example where that's the case. It is a shocking thing. And it's so much embedded into the way we're operating that people aren't shocked, and that's terrible. But we pay the most and get the least on healthcare. That is a fact, right? And whether you're a liberal Democrat or a conservative Republican, that should be shocking to both of us, because we literally pay twice as much as most countries, and our health care outcomes are not the best. You know, infant mortality, longevity, they're not the best. And it's not an answer to that reality that, yes, it is true that in many cases we get extraordinary health care. All right, that's a good thing. But you have to have something that is sustainable and affordable over the long run. And you know, we have a real situation here with the Medicaid trust fund, or the Medicare trust fund. I guess, 5 years it's going to be depleted. We've got a situation with our small hospitals and all our hospitals that is really profoundly and acutely urgent, especially in rural communities. You know, about 46% of our small hospitals are in the red. I mean, that's serious infrastructure, especially in rural America. Since 2010, over 150 hospitals have closed, and a third of all rural hospitals in the country are now at risk of closing. So in these healthcare costs, you know, we're seeing it right now with this whole issue about the expiration of the tax credits. That's going to be murder for a lot of folks who are depending on them in order to be able to buy health care. You know, I had a farm, this is a very concrete example. I had a farmer in Vermont call me up, and he was a Trump voter. He's a wonderful guy, incredibly hardworking, pillar of the community, self-reliant, you know, all these virtues that all of us admire. And he said to me, Peter, if you guys don't extend those credits, don't worry anymore, because I'm not going to have health care. His premiums were $900 a month, and they're going up to $3,200 a month, okay? So that's just an example of what our failure to act is doing in the real world to real people. And this issue on health care and how expensive it is, it knows no political limitations. You know, you're a Trump voting, hardworking farmer in Vermont. You're a Harris Democratic voter elsewhere. You face the same thing. In the bottom line, you want to make sure your family gets protected. So the fact is that we have to address some of these structural issues. And the notion that the private sector is going to help us do that is wrong. The private sector, in many cases, is exploiting the market opportunities that are in our chaotic and disorganized healthcare system. But I think on our side, the Democrats have to appreciate that just adding more and just increasing the payments without addressing the cost drivers is not sustainable. You know, from in my point of view, I'm really oriented towards access, and I think most of us are. You can't have access unless you have a sustainable financial picture. You can't be having these premiums go up as they are so much. But you also don't address the access problem or the affordability problem if your way of controlling healthcare costs is to kick people off of healthcare. And that is shocking. That's what happened, all right? With the one big beautiful bill, 15 million people are going to lose health care. They're not going to lose health care problems. Every single one of those people at some point is going to need health care. The only difference between before and after is that they had coverage, and now they don't. So what happens? They show up at our community hospitals, they get care, the community hospital gives further, and they go from black to red or deeper into red, and eventually it's not sustainable and adds to the closing. So the notion that you control costs by taking away access, by taking away coverage, well, that'll work when you can also guarantee people don't get sick. That's not going to happen, all right? So how do we, how do we deal with this? And it's important not just because access to health care is so critical. It's important because it's one of the major drivers of this incredible out-of-control deficit that we have. So, when we talk about a deficit, it can't be just tax more or spend less. It has to be looking at some of what these incredible cost drivers are. And of course, Medicare, Medicaid, and private insurance is all a big part of what the expense is, and we've got to address that. So, I think there's got to be some acknowledgement in the political process here in Congress and elsewhere that this is not about just squeezing on the access side. It's not just about taking away people's coverage. And it's not as though the private sector is going to be our savior here because the market distortions are so embedded in it. I believe the goal for us should be to have a universal health care system where people have confidence that they're covered and they're paid. I mean, other countries have that. We can have it if we can solve the political impediments that are on our way, but that should be the goal. But to achieve that goal, there's got to be, as I say, a recognition that we can't just keep adding and seeing the expenses go up and up and up. So, the ACA was a good step. It did start bringing down the cost with some reforms, but not enough because we've seen those premiums go up and up and up. And it's not going to be a sustainable situation in the long run. But what I believe we have to do is I personally am in favor of something like a Medicare for All plan. Saying it doesn't solve it, okay? But what it does, I think, state quite explicitly is that our shared political goal should be a sustainable healthcare system where everybody has confidence when they need care, they'll get care, okay? That's how I see it. I also see it as a way where we're acknowledging that we have to have significant reform that helps that level out the cost, keep costs down, and not have the distortions in the marketplace end up being enormous burdens on the taxpayer and on our businesses that are buying health care insurance for their employees. And this is a brutal situation for most of our employers because they have this tension every year about do they give a raise or do they give the raise to the insurance company to pay for the increase in the premium. And of course that's creating an immense amount of anxiety for our families that are dealing with the affordability issues that we know about. So, two things I'm saying here. One, if we care about bringing our deficit down, which we have to address some of the cost drivers in health care, and the enormous increase in premiums every year have to be addressed. They can't be ignored if we want to have any success. And that two, if we want to have a society that works, we should have a healthcare system that is sustainable and does cover everybody, and it doesn't depend on whether you work. It doesn't depend on whether you're poor or rich. It doesn't depend on where you live. So the idea that, I'm repeating myself here again, but the marketplace is not going to pull this off. Now, we're not going to get to some Medicare for all outcome. There's a lot of work involved in that. There's a lot of different ways it could be done. In other countries where they do have universal health care, there's some places where they have private insurance. There's others where it's essentially government funded. But there's a variety of ways it can be done. But the North Star, I think, that should be shared is the goal of universal health care and the acknowledgement that you can't have that unless you deal with some of the structural cost drivers. There are some things that we could do in the short run. You know, Medicare Advantage. The Trump administration actually did a good thing just today. Instead of the 4 or 5% increase in premiums that the insurance companies wanted, and they've been abusing the coding process wickedly, okay, there's going to be a 1% increase. If we don't get Medicare Advantage under control, that's another $1 trillion over the next 10 years. PBMs. You know, the way we price drugs in this country works for everybody but the patients and the taxpayers. Literally, okay? We pay you guys all know this, but we pay by far the highest, usually 5 or 6 times what others pay. And why? There's no justification for that, in my view. And the notion that it is what we have to pay for innovation, I don't buy that. That's the kind of excuse. But when you have these wonderful drugs, and my first wife had cancer, and her life was extended and her pain was relieved. So I'm so appreciative and aware of the benefits of the extraordinary medications that we have that can be pain relieving and life extending. You can't have the price be so high that it's going to kill you. And that's essentially what's going on. So there has to be a capacity to bring down these costs, and that's a major driver in the healthcare cost. So PBM reform, prescription drug pricing reform, value-based medicine, which was an effort that we had in the Affordable Care Act, which makes sense, by the way. You pay to keep people healthy. You have a much stronger emphasis on primary care, on community health services and public health, which are so much more important to the well-being of people on a day-to-day basis. When they get an acute illness, then a different kind of treatment is important. But if you have public health measures, you have access to primary care, you have it in a way that's convenient and not complicated, then that's going to keep people much healthier. And obviously that can help keep the cost down. So this is probably one of the biggest issues that we face, both from the perspective of our deficit, that is a growing problem, and we're going to ignore it until we can't. And when something bad happens, do we have the flexibility to adjust to it? So I appreciate this organization for constantly focusing attention on the need for action. But second, there has to be some recognition that there is a focus that we have to have on the structural issues. We're talking today about healthcare, but the way our healthcare system is working is that it is an incredible profit center for some private enterprises, private equity even getting into buying up doctor practices. How is that really helpful? So the market is not our friend here necessarily, but on the other hand, the notion that somebody like me who really wants access to be universal, that we're going to simply get it by spending more and more money without reform, I think is a notion we've got to give up. We've got to look at the structure of our healthcare system in order to achieve the twin goals of access and affordability. So I thank you for your work. I thank you for inviting me. And I wish you good luck in the rest of your conference. And by the way, whoever thought of that hot chocolate? I hadn't had hot chocolate. This is not the way to end. But I couldn't believe it was 15 below in Vermont. And Margaret comes out and gave me some hot chocolate. I hadn't, and I got my second one here. So I want to thank you for that. Thank you very much.
Thank you, Senator Welch. And I had a feeling it was the hot chocolate and not the sick of your kids part. If the first panel wants to come on up, we'll get moving with the rest of the summit. So this first panel, we're going to focus on the Medicare program, which just happens to be the largest federal government program related to health care, second largest overall. As I think many of you in this room know, Medicare served about 70 million people. Anna mentioned earlier, it now costs the federal government $1 trillion a year. It costs the beneficiaries hundreds of billions of more in terms of their premiums, their out-of-pocket costs, et cetera. And the Hospital Insurance Trust Fund, the Part A trust fund, is less than 7 years of insolvency. It is projected to run out in 2032, right around the same time as Social Security. And so we have a great panel that's going to talk about every aspect of Medicare, including taking your questions. A couple of housekeeping things. I see people standing in the back. There are a few chairs here and there. Also, we're going to take questions from the audience that I am going to ask. What I'd like you to do is, if you have a question, write it on a page of your notepad, rip it out of the notepad. We got very cool Health Solutions Summit notepads. Hold up the paper, and somebody will be around to pick it up, and then I'll just kind of ask your questions, or I'll pretend to ask your questions and make up my own, whichever I'm feeling. So first of all, please join me in welcoming our panelists. Their bios are in your program, and I'm not going to spend a lot of time on them, but we have Ben Ippolito from the American Enterprise Institute, Elinor from Alston and Bird, and Tricia Neuman from KFF. I just want to jump in with some discussion. I'm going to start kind of high level. The big buzzword, it seems like, is affordability, right? Everyone's talking about affordability. Tricia, I'm going to go to you first. What the heck does that have to do with Medicare?
Well, that's a great question. And first, thank you, Marc, and for everybody for inviting us and for showing up on this cold, snowy day. I think everybody's a little house crazy, maybe. That could have been that plus the cocoa. What's it mean for what's affordability, and how does it connect to Medicare? Well, Medicare affordability issues are obviously important for the federal budget because Medicare is a large share of the federal budget. But Medicare spending also contributes a lot to out-of-pocket costs for people on Medicare. So when Medicare spending goes up, that means premiums go up, it means deductibles go up. We were sort of surprised to see, we looked this year, we looked at Part B premiums, so that's for those of you who are not Medicare wonks. Medicare Part B is covering outpatient services, physician services, and Part B drugs. Today, 7 million people spend more than 10% of their income on Part B premiums alone. So rising costs, and this is not the part of the program that has to do with the Hospital Insurance Trust Fund, rising costs in another part of the program has a direct impact on what people pay. So we want to think about Medicare spending both from a perspective, the broader perspective of the federal budget, but also from the perspective of the 67 million people who rely on the program, many of whom live on fixed incomes and can't afford these rising costs.
Thanks. Ben, I'm going to you next. It's been mentioned a couple of times now, once by me, that we're spending $1 trillion a year on the Medicare program at the federal level. That's risen significantly from just a few years ago, and it's projected to continue rising. What's driving those costs? What's driving the high and rising costs of the Medicare program?
Yeah, I mean, the sort of scariest thing, I was just at the budget committee, and we were talking about, the rising healthcare costs, and one of the sort of scariest underlying facts of this too is that Medicare and overall health expenditures have actually been growing at kind of a modest and pretty heavy quotation mark rate for the last 15 years or so, roughly in line with GDP. But even with that, we're at close to 18, or we're at 18% of GDP now. Medicare, it's sort of a tale of two programs. Right? On one hand, we have traditional Medicare, where predominantly the problem is trying to control the use of services. I mean, there have been decades of analysis at this point pointing out, we heard it, Miami does a ton of services, and we have a real hard time controlling services there. Meanwhile, some other places seem to deliver similar care with much less intensity, much less use. Figuring that problem out, there's some pricing challenges in traditional Medicare, but that seems to be sort of the first stage. Medicare Advantage, it's a different story. It's sort of prices, essentially. It's how much we're sending to the insurance companies. They do a pretty good job managing care. People are making a trade-off when they enroll in MA. They're getting some constraints on the care they use. There's a network. They can't go to every single provider, but they get a lot lower out-of-pocket spending. We did some work that if you run the same person through, like a hypothetical person through, it's like 20% lower out-of-pocket spending in an MA plan. But it comes with all of this management. Well, if that management doesn't actually translate to lower spending by the federal government, we're not really sharing in that benefit. And so that seems to be the big challenge in the MA program. There have been meaningful improvements, it seems. We can talk about it, new risk adjustment and all sorts of technical things seem to be lowering materially what we're spending in the program, but that's the big challenge.
Thank you. So I'm going to jump in the fee-for-service for a second, right? Because Elinor, you've done a lot of work about thinking about different payment models and looking at CMMI and elsewhere. But traditional Medicare is still fee-for-service. Can you explain a bit like how does that work, and to what extent is that driving up costs either in the affordability angle or for the federal government?
I think when we talk about affordability, we always have to think about affordability for who. So we've talked a little bit about affordability for the beneficiary. What are they paying on those Part B premiums? What are their costs when they go to see a doctor? Does Medicare fill in those costs so that care is actually accessible at the individual level? We've talked about affordability for the taxpayer and how much these programs cost overall. And we also have to have these programs be financed at a level where providers participate in them. I think the trend in terms of fee-for-service includes a lot of visions related to value-based care. Sometimes you now sort of see charts tracking enrollment, not just in Medicare Advantage and original Medicare, but also within that original Medicare population, who's in ACO models, where
accountable
you do
care
have
organizations.
Accountable care organizations, where you do have that level of accountability for an overall budget, or at least targets related to the overall spend for an individual. So you have opportunities to have more care management by entities that are participating in innovation center models, but there are also parts of the fee-for-service program where individuals truly aren't having their care managed. And the benefit of traditional Medicare allowing any beneficiary to see any provider who participates in Medicare means that there is a lot of choice, and that individuals may be navigating the system on their own in ways that allow them to have care patterns that you wouldn't see in a managed care environment.
Great. Did you want to jump in, Tricia? Seemed like you're...
No, the only thing I was going to add to that, and I don't disagree with anything, is that traditional Medicare also provides some price discipline generally because, as Kim was saying, Medicare is a lead payer. And so other payers have a benchmark to use when setting prices for physician or hospital services. Now, commercial insurers tend to set a much higher price relative to Medicare, but there's something there. There is a level to attach to that can be used to establish discipline on prices. Whether or not commercial insurers can use that or do use that is a different question.
I mean, it does directly affect Medicare Advantage as well. I mean, there's this kind of, the Medicare policy, debate occurs kind of in two, separate silos to some degree, but like this pricing piece of the fee-for-service side of the ledger turns out to be actually really important for Medicare Advantage not being more expensive, which I do think is sort of an underappreciated piece, even among people who like Medicare Advantage. If MA does not need to compete with traditional Medicare to attract enrollees, it is going to be a lot harder for them to credibly negotiate with a hospital for a lower rate. Because as it stands today, Medicare Advantage plan can very credibly say, if Sibley does not give me a lower price, I cannot enroll anybody. I cannot possibly attract a premium. I'm not going to attract anybody away from traditional Medicare. So there is sort of this spillover effect, too, that we do need to grapple with a little bit if we go down the MA route further. But that's
which we're about to, but not before you get your first CRFP plug of the day, which is that we put out a paper recently as part of our Health Savers initiative that thinks about using Medicare prices to do reference pricing within the FAHB program. And so there are ways you could actually use Medicare to kind of further pull down commercial costs. But I do want to jump into Medicare Advantage because now more than half of enrollees are in the private alternative to Medicare rather than traditional Medicare. MedPAC just had a great report that came out the other day that said that we're overpaying these plans by about 14%. I think it was $76 billion, maybe it was 78, I forget. But somewhere in the $70 billion for a single year relative to fee-for-service. We did the math over 10 years. It's like 1.2 trillion. If you want to argue with us, maybe it's only 1.1 or 1 trillion. It's a massive amount of money, right? A lot. Ben, I'm going to go to you first. Like, where's this extra money going? Is it profits? Is it golf fees? Like, what's happening to it?
I did read Chris Pope at the Manhattan Institute is really on this, and he has dug up specific plans with specific golf courses that are covered on the MA. So if you're in Southern California, he has some recommendations. So first off, the one thing I would say is that this conversation really does, from a budget perspective, it makes sense to compare how much we spend if somebody enrolls in traditional Medicare versus MA. I don't really think that's actually the most policy relevant thing to evaluate, because whenever I talk to committees or offices, they care about if we change what we pay MA, what are people going to tell me happened to their Medicare benefit? And so in some ways, I do think it's important to sort of frame this as there's a trade-off between what we spend and what people get. That's really what we need to sort of grapple with. Where is it going? MA plans clearly are able to generate some cost efficiencies. They constrain networks, they constrain use of care, they don't let Miami get away with what traditional Medicare lets Miami get away with. That generates savings. They also enroll relatively healthy people. They also code relatively intensely, and so that generates this huge delta between what they're sending out the door for claims and what they're bringing in. They do spend a lot of that money, though, I will say. We did some work that estimated that just the reduction in cost sharing accounts for close to 2/3 or 3/4 of all of that excess spending. So people get benefits by it. But there is also evidence that says that the last dollar they're getting passes through very imperfectly to beneficiary benefits. And so the reason I sort of led with that framing about this benefit trade-off with spending is that that's the key thing that we really need to care about is as we dial down payments or adjust payments or whatever, when does that trade-off actually become more meaningful? If it's just the golf courses, the ski passes, the literal debit cards that we're handing people at this point, I'm less worried. If it's more substantive, then I think people really are going to notice.
I want to push that a little bit, and maybe Tricia wants to weigh in. But we had a debate in this country a few years ago about whether to add dental, vision, hearing benefits to the Medicare program. And it was basically decided, through the political process, it wasn't worth the cost. But yet we're effectively doing that in the Medicare Advantage program in sort of a backdoor way, where they're, for lack of a better word, they're lying about how sick their enrollees are in order to get more money, and then they're giving it back in the form of dental and vision benefits. How do we start to evaluate whether that's worth it if there's no political process in the way? And how do we even think about whether people are getting good bang for their buck and whether the taxpayer is?
I won't jump ahead. I'm sorry to monopolize here, but I will say that one of the big problems is that we don't even know necessarily how much we'll use those benefits, let alone how much they actually care about the benefits. And so as a first order of business, that seems like an obvious thing to solve. But anyway.
Yeah, I don't disagree with that, and I think it would be very helpful to know how the dollars are being spent. And we're getting more information from MedPAC on that. I do think plans compete. If you look at ads, and I'm sure you all have seen ads for Medicare Advantage plans on TV, we did a study about them, and there's like 0 premium plan, not mentioning the Part B premium, extra benefits, debit cards, all the goodies is what they're really promoting in order to attract people. Dental, vision, hearing. That's appealing to people who are living on fixed incomes, and they're providing some of that, and people are getting some of that. But because that is sort of the main sort of shiny nickel for people, I think they might look for other ways of achieving savings first. So while I know the lobbying has already started, ever since the advance notice came out like a minute ago, I think what I think is plans are going to respond very differently. And I do think they're going to look to retain benefits as much as possible because that's retaining market share. And I think, a gradual change may not create the backlash that people fear. And I think it raises a question that's worth thinking about, which is, what is the policy motivation for providing extra benefits to half the population? And what are the trade-offs? And there are trade-offs involved. For example, the $80 billion that you mentioned, or close to $80 billion that MedPAC has found, contributes to higher premiums, getting back to the premium example that I gave you, paid for by people in Medicare Advantage and people in traditional Medicare who are not getting those benefits. It also puts pressure on the Medicare Hospital Insurance Trust Fund, which I know you want to get back to. And it also has this other effect that's not getting that much attention, but plans have rebate dollars, and I think they're higher than they've ever been. And about 1/4 of those rebate dollars are used to buy down the Part D drug premium. So what that means is Medicare Advantage plans are able to offer these zero premium plans, and people in traditional Medicare are going to standalone drug plans that cannot compete against Medicare Advantage because they have to have a premium. So we have created this sort of structural problem within Medicare that is sort of an incidental, I think, an unintended consequence of the current payment system. And that is something that I think does need some thought.
So I want to talk a little bit more about the gradual change because I read this MedPAC report very intently, and I saw actually there was some pretty good news, which is the overpayments are significantly lower this year than what MedPAC had expected them to be. And that they attributed it largely to something called V28, which I'm told is not a very nutritious vegetable drink, but rather a new way of doing risk adjustment. Elinor, can you tell us a little bit about V28 and how it's working?
Sure, and I think it's helpful to just level set a tiny bit about the way Medicare Advantage payments work and the way plans get paid. So plans have to bid against a benchmark. The benchmark is a product of fee-for-service spending in any given county and a formula. But plans then are incentivized to bid lower than that fee-for-service driven amount, and it's based on how much lower they can bid than that in order to then pull down a percentage of the difference between those two numbers, which become these rebate dollars that were talked about. And that's the discrete pot of money that plans can then allocate towards some of the supplemental benefits, but which are by definition benefits that aren't available in traditional Medicare. And supplemental benefits have historically been very focused on dental, vision, hearing. That's also the same pot of money that you would use to buy down premiums, either on the Part B side or the Part D side. And then we've had a more flexibility given to plans in order to offer additional types of supplemental benefits like grocery cards or transportation or fitness benefits, et cetera. So that just structurally, the bid includes all of the original benefits, and then where you're playing around on the margins is based on how many rebate dollars you can pull down, which is more complicated than that for all sorts of reasons we can get into. But I think fundamentally, the amount that MA plans get paid is also a function of the individual risk scores of the population that they end up enrolling. So on top of that basic bid amount, then you have adjustments based on the risk of your population. That's where I think there's been a lot of conversation. So the previous administration introduced a new risk adjustment model called version 28. There have been 28 risk adjustment models, and this not all of them get implemented, but this is we moved to V28, right? So V28 took out a number of diagnosis codes, so certain diagnoses that CMS felt were no longer actually predictive of risk. So being able, even if a diagnosis is properly coded and appears in someone's medical record, the risk adjustment principles require CMS to then figure out which diagnoses to include in their model, right? So everybody may have diagnoses. Some diagnoses, they're totally under control. They're not predictive of your healthcare costs, et cetera. Other diagnoses are predictive of how much care you might need in the future. So the risk model is trying to get at that set of diagnoses. So V28 was a fairly dramatic change, and I think given the desire for some level of stability, CMS decided to phase that in. So that model will now be completely phased in. And now, one thing that's interesting about MA policymaking in general is that when new administrations come in, they usually arrive to some amount of baked policy, and then they get to finalize it. So 2027 is actually the first year that the current administration is doing the whole process from start to finish. And in addition to the rule, that includes the rate notice and the advance notice, and that's what we've all alluded to as what was released on Monday night. So the current administration proposes some adjustments to V28, including adjustments to the data years, and they are also making proposals related to the source of diagnoses that are risk adjustable. that will also, I think, is generating the reactions that we've seen.
Yeah, can we talk a little bit more about that? Because I got a question and because you brought it up, but I just saw United Health stock tanked. I didn't really see the other news, but I know that I'm not an owner of it. I put all my money in treasuries. It's a joke. But I saw the administration proposed essentially no increase in Medicare Advantage payments year over year, and they're going to remove sort of these risk assessments, which I know was something in No Upcode Act, et cetera, or they're talking about it. Can any of you tell us a little bit more about what is being proposed and what do we think is actually going to happen?
Sure. So I think first, there's a paper that's worth reading that was published in Health Affairs Scholar by the political leadership of the Center for Medicare, where they respond to some of the MedPAC calculations, and where they, I think that their view is that the coding differentials are not as dramatic as MedPAC sees using their methodology, but they nonetheless identified in that paper some degree of coding differential. So reading that, I think it led potentially to the advance notice that we see. So I know that there's been a lot of buzz related to health risk assessments, which you raised. They have not proposed changes directly related to health risk assessments. I think the biggest change in terms of source of diagnosis that's been proposed is to require linking of chart reviews. So right now, plans are able to review the medical records of their enrollees, identify diagnoses based on those records, and they can submit those either linked to a specific encounter, clinical encounter, or unlinked. So you can have a chart review and submit that diagnosis for risk adjustment without necessarily linking it to a specific encounter. So what they're proposing is to require linking, and that has been proposed in conjunction with other policy to reduce reliance on health risk adjustments as a source of diagnoses. That is part of No Upcode Act, but the policy that they've proposed is discrete to just the requiring linking.
Right. The combination of these two, I kind of think this is a sneaky big moment to learn about the MA program, because we have long talked about what if we adjusted like how much we paid them and how we paid them and so on. And we have a combination of two things where the changes to this new risk adjustment model where you're trying to make it harder to upcode, reduced overpayments from 21% to 16%, something like that. That's a lot of money. The latest advance notice proposes a very small increase in payments to MA plans. The combination of those two things is quite a change from a trajectory that has generally been sort of increasing over time. And so it is at least an opportunity to learn a little bit about this big trade-off that I get asked about a lot and policymakers care a lot about, which is how is everybody going to respond? Like what is the strategy and what's the magnitude of the response? How much comes out of profit from insurers? I mean, United stock tanked like 20% yesterday, which tells you something about number one, the exposure that these companies have to the MA program is enormous, but also how big they think the change is. And then the second question is how much of it comes out of benefits? What benefits? How do they approach that? Up until now, MA, you make money on everybody. And so you allocate a huge share of the rebates that you have just to knocking out deductibles and premiums for everybody. It's nothing fancy about trying to attract special types of people with granular strategy. It's just get anybody in the door. Well, investors are asking questions about whether that strategy is still viable in this new model, or whether we need to think more seriously about margins per enrollee versus just enrollments and so on. And so I think this is actually, among other things, going to be a very important moment to actually learn something about how strategy changes, what it means for beneficiaries, and then kind of reset our thoughts on, okay, what's the next step on the policy front?
Just a reminder, if you have questions, again, write them in your notebook, rip it out, hold it up. There's a gentleman up front that's holding up his. I'm going to try to keep our discussion of Medicare Advantage to 55% of the conversation, since
Perfect.
It's 55% of all enrollees. But the last question I'm going to ask is, so there's another program about kind of waste fraud in the program. There's another program called RADV, which is not that same vegetable drink with radishes added in, but it's a sort of an anti-fraud program that I know had some challenges in the courts. Does anybody want to discuss what the status of RADV is and what it's doing or not doing?
I'm happy to start. So the risk adjustment data validation audits are CMS's way to identify whether specific diagnoses are valid. So validating those diagnoses validates the payments, and it's the RADV audits use a very similar methodology to how CMS has traditionally measured improper payment rates in Medicare Advantage and Part C. So the RADV program, I think, has announced different methodologies related to how they're going to proceed with picking which plans to audit, then conducting those audits, and then once they have findings, collecting dollars on the basis of those audits. And a lot of the debates over the years have related to how their findings compared to the fee-for-service baseline, and whether and how they can extrapolate their findings based from the sample of claims that they're looking at, or the sample of beneficiaries and diagnoses that they're looking at, to potentially a plan's full population. So they've been behind on RADV audits for a long time. These audits are resource intensive. At the start of this year, we saw CMS take great strides to move ahead and try and catch up on RADV audits. And expand from reviewing a smaller number of contracts to a bigger number of contracts in each year. And then after they made that announcement, there's been a long-going lawsuit where the plan that had challenged some of the methodology prevailed. And the question has been how and if that would throw a monkey wrench into CMS's plans to be more aggressive in proceeding with RADV audits. They released an updated memo this week about some of their their plans, which include proceeding, but I do think that they still have potential headaches based on the action in court.
All right, let's move on to fee-for-service for a bit. I think everyone's kind of favorite policy option is moving to site-neutral payments. Most people in the room probably know what's going on here. Medicare pays, in general, more to hospitals or hospital-owned physicians' offices than to private doctors for pretty much the same services. How did that happen in the first place? Just come someone tell me, how did we get these site-unneutral payments? Where did they come from?
I wasn't there. I don't know. I mean, the argument is always that hospitals have to maintain this big fixed cost, and you got to run the emergency room. It's got to be open all the time, and it is true that they have larger fixed costs. That has been sort of, in my personal view, kind of bastardized into, well, for everything we do, we need to make sure that we get this higher reimbursement. I don't know. At this point, it seems like everybody either agree that for services that can be safely done outside of a hospital, that we ought to move to the lower reimbursement rate. Either you agree with that or you don't, and I don't really know that anybody's changing any views at this point. It sort of seems like the same people beat the same drum, and we see where the political will is, but I don't know.
Yeah. No, I mean, I think there are some services where you want different options available to people, right? There are, my husband just had his appendix out at an outpatient, ASC, right? That was great for him. He could come home the same day. There are other people for whom that surgery would really be most appropriate in a hospital setting, right? So you want both. You don't want to say well, this is the lowest cost setting and therefore the only setting. And I don't think you'd want to say that those costs are going to be the same in both of those settings for the provider, right? It is complicated, right? It always sounds simple, and because it's healthcare, it's always complicated.
There's some truth to the counter arguments, and so I think the only realistic goal is to try and pick the most sympathetic cases where it is just the hardest to make, the case. Like drug administration has long been a perfect example. That's an easy one. That's a really hard case to make that you really need somebody to be in the hospital to do.
What is I've been hearing about, the first time I heard about site neutral, I think was like in Orrin Hatch's office in 2009 or something like that, right? People have been talking about this forever. It's in the Obama budgets and all the first Trump term budgets. The Biden budgets didn't actually have any Medicare stuff, but it would have been in there, right? It's got Elizabeth Warren supports and Newt Gingrich. What's stopping it from actually happening?
I mean, I think it's a little bit of what everybody's been saying. It sounds really good, right? And if you think about it, you're like, why should we pay more for something just because it's in a different setting? But what we've seen, for example, the bill that may or may not pass the Senate is when the rubber hits the road, there seems to be some reluctance to move forward in a really ambitious way. The current proposal that's being talked about would increase transparency, make information more available, so that would be helpful to potentially commercial insurers, but it's not the really big proposals that are like $150, $160 billion in savings. And I think it's because there must be some trepidation about the potential implications of doing that and what it could mean, or it could also mean there's not a lot of pressure right now to engage on serious policy matters related to Medicare savings. We haven't really had a serious effort at deficit reduction. I feel like I am so preaching to the choir here in many, many years. And so there haven't been tough decisions that policymakers are forced to make. I mean, when I got my training wheels on, when I was working on the Hill, we were doing deficit reduction, budget reconciliation bills every year. And that forced committees to really think about what's the least bad thing we can do to reduce the growth in Medicare spending. That's not the framing for congressional discussions right now.
Yeah. Okay, but with the second CRP plug, I'm going to tell you that last week we released a paper on what a fiscal crisis might look like. And it's not that we think that one is around the corner, but when your interest rates are as high as your growth rate and your debt is pushing them further, you can get into a debt spiral quicker than you would think. And we've seen countries like Japan have high debt for a while and be okay, and then all of a sudden not be okay. We're seeing the same in Europe. And so that deficit conversation could come back sooner than any of us think. When it does, I'm assuming site neutral is going to be in the discussion. When it does, I assume Medicare Advantage is going to be in the discussion. What else is going to be in the discussion? Where are there spaces, fee-for-service particular? We used to talk about a lot about post-acute care payments, about bad debts. What are the areas where there may be kind of room to run if we're having one of those conversations in Medicare?
I always think prior authorization, some type of constraints on use in the traditional Medicare program. That's a really, really difficult political conversation, I think, to have for a lot of people. But if you have a crisis, maybe you find some of those arguments a little bit more compelling. Putting not Medicare Advantage style constraints, but some constraints on how often services are used in the traditional.
So there's been some efforts to start to do that, right?
Yeah. So the current administration is I think it's a pilot. Yeah, it's a CMMI demo where they're going to test for a set of 10 services where they are trying to identify services that are the most compelling case, where they think there is both evidence of existing overuse of low-value services and the possibility of actual harm from getting these services when it's not appropriate. I don't know the full list. I want to say skin substitutes was on the list. That was the only one I recognized.
So we've been taking a look at the Weiser model, and skin substitutes they are the elephant in the room. That's like the big ticket. And the issue with that is CMS kind of on the one hand is doing the Weiser model, but on the other hand is doing a payment reform. So, it may be the payment reform that has the largest effect on utilization and spending. It's a little bit too soon to see. The other items may be arguably unnecessary. I don't know, I'm not a clinician, I have no idea. But they're smaller ticket items. And I will say, prior authorization is really unpopular. And so the question is this the sort of, from a policymaker, a politician's point of view, is this really the way they want to move forward? If there are other ways to achieve savings that don't potentially lead to delays and denials of necessary care. I would have put more work on prescription drugs on the table, perhaps post-acute care.
Physician-administered drugs.
Physician-administered drugs. I think the negotiations program could expand a bit. I mean, I just think there are other ways to go at this which may be more popular.
Yeah.
Before I get Elinor's answer, can you just unpack a couple more sentences on the physician-administered, the Part B drugs, and what's going on there?
These are drugs. A lot of these are physician-administered drugs. So these are infusion drugs. These are drugs that are taken by seriously ill patients often. And a clinical setting, and they are subject now to, as of 2028, they will be a part of the Medicare negotiations program, but they are not offered through Medicare Part D. The standalone plans are offered through regular Medicare, so people are paying a 20% coinsurance on fairly high prices, and so these high prices for these very expensive drugs have spillover effects both for Medicare and for people who are stuck paying the coinsurance.
I would say it's one of the places where Medicare is as passive of a payer as anywhere. It basically takes the average commercial price and just pays that and moves on with it.
I think gives the doctor a bonus as a percent
and
on
then
top
gives
of
the
that,
doctor a
right?
bonus as a
And
percentage
that's been a
of that
tough one.
price.
That's been really
Right.
hard, and there's been a lot of
Yeah.
pushback in past administrations that have
Yeah.
tried to go after oncology drugs specifically, because the oncologists get paid more if they administer a higher priced drug, and the oncologists would say that's because that's the drug we think we should be administering, and of course patients then recoil and say, well, wait, if that's the best drug for cancer, we don't want to interfere here. So there's there's an obvious tension there, but there's potentially work to be done.
Elinor.
Well, I was going to go back to Weiser and prior auth and this conversation about, how much prior auth drives people crazy, but and the sort of the hope that I think Weiser rests on, which is that we can use technology to find a way that we can adjudicate prior auth decisions quickly, effortlessly, in ways that create fewer headaches. But sometimes when people are mad about prior auth, they're mad about the process, and sometimes they're mad about the coverage policy. And I think one thing that's interesting about the skin substitute thread, which Kim talked about it, we can all talk about it, we can't leave the stage without talking about skin substitutes, is that CMS is using this Weiser model, but they haven't really, they've done their payment policy, but they haven't yet updated their coverage policy for skin substitutes. So I do think that's worth thinking about on the list is how fee-for-service, whether fee-for-service Medicare has enough resources in the CCSQ, in the part of Medicare that is charged with doing these coverage decisions, or at the MAC level, because a lot of Medicare fee-for-service operates without a coverage decision in place. It's just based on what's reasonable and necessary for an individual, as opposed to where a coverage decision is available, and that really stands in the place of a more personalized, reasonable and necessary decision. Sometimes I think that's the crux of people's frustrations with the way prior auth works in commercial or Medicare Advantage is that there's a coverage decision that people don't feel meets their personal needs. But that's a push and pull between making a decision based on a population or leaving decisions about what care is necessary really in the hands of the patient and the individual. And this is a balance.
We just put out a paper today led by my colleagues that said Medicare Advantage plans, there are 53 million prior authorization requests in the most recent year of data that we had available. And I think there's something like 8% of denials, which makes me wonder, that's a pretty low yield for the number of requests that are out there. Now, it could be because of documentation issues, it could be for a lot of factors, but to your point, it's the hassle issue that I would not like to see transported to traditional Medicare. Although I do think we all want to look for ways to be sure that there's not unnecessary care that people are getting that are driving up spending. I just kind of don't want to torture people in the process. So gold carding is something people have talked about, letting physicians that have a good record just sort of get a pass. I mean, maybe there are other strategies of going after outlier providers so that sort of the middle is kind of left alone to get their medical care, because they're obviously not getting denied a lot of services. So there's things are happening around the edges, and they must be worth the effort, because there must be effort involved by the companies because they're doing this. But it is creating bad will, and I don't think we want to create bad will as we look for ways to make the programs operate better.
But not so much bad will that the Medicare Advantage enrollment isn't growing by tremendous percents per year compared
That's true. But people, a lot of people can't afford to not go into Medicare Advantage. When we've done focus groups, people say, sure, I'd like to have wide choice of doctor, and I would like to not have a network, and I would like to not worry about prior authorization, but I can't afford a Medigap premium, and I need these extra benefits. So there's a little bit of that going on too.
Do we think any of that low percentage, you say it must be worth the return for them doing it, is sort of because there's a deterrence effect?
Yes. Yes, that's all.
So
Yeah.
we're not
it's all the
prescribing
deterrence.
things that we think are going to get rejected.
Yeah, that's the key.
Let me turn for a minute to drugs, and then I want to ask some of the audience questions. How are the negotiations going, and how do they interact with the most favored nation voluntary and mandatory prices of the administration?
How are they going?
You want me to start?
Yeah, go ahead.
Okay. Well, I think they're going well. The first round was estimated to achieve $6 billion in savings. The second round, $12 billion. That has something to do with the number of drugs and the type of drugs that were in the second group that were selected. The administration just announced the third round of drugs that will be negotiated. So that process is ongoing. I think there is an issue of, there was a provision in the One Big Beautiful Bill that would create a delay or an exemption for certain orphan drugs that may have limited the savings, that did limit the savings that could be achieved through the negotiations program. But I think it's going. I can't answer the question about how the models are interacting. I think we're still learning about the models. I don't know if anybody else wants to comment.
Or even just what is going on with the most favored nation? I'll ask a simpler, not that simple, but.
Well, so I think the current administration has taken a novel approach, right? Instead of waiting for Congress to say you can negotiate and then import prices to Medicare Part D or Part B, they just hauled in the pharma CEOs and kept them there late and signed a piece of paper, and I think one thing they're testing is the effectiveness of these sort of handshake agreements. But then, of course, the process always comes into play, and of course, it's complicated. So we have 3 different models. We've got Guard, Globe, and Balance that sort of paper the way in which the prices that have been really directly negotiated on some scale with the manufacturers get imported into these public programs and how they interact with the other aspects of the pricing model. So, I think they've had quite a lot of success in getting people in the door, getting people to agree to lower prices based on these international benchmarks. And then we have proposed rules, at least on the most favored nation side, to make it so.
Well, there's the demos too, right?
Those are Globe and
because they're mandatory
Right.
Innovation Center demos, they've gone through the Federal Register as proposed rules. But they use the IRA structure of the inflationary rebates and adjust those rebates on the back end. So it really gets back to, on the Part B side, trying to not disrupt the current flow of ASP plus the average sales price plus that 6%, where an oncologist could still be paid up front, but then if the price remained higher than the international benchmark price on the back end, you would see a rebate back to the trust fund. So it's, I think they're creative solutions. They started with, I think, really open discussions. And I think a mandate from the president to try and get to certain prices on certain drug products. So we'll see.
I do think it's going to be very interesting. So these demonstration projects that I guess are mandatory demonstration projects to test the use of most
And the
favored.
test is that these prices are only going to be for 25% of the
Right.
population.
So I think this is going to be interesting to watch, partially because it could be quite impactful because those demos can be expanded nationwide. Thus far, we have not really seen a full-throated lawsuit against CMMI's authority. This is really going to generate well-heeled lawsuits, lawsuits from well-heeled individual or companies, alleging that CMMI, this is beyond their authority. This is not testing anything. This is just setting a price. This isn't a payment model. This is just lowering a price and beyond. I think there's going to be major questions, challenges, and so there's a lot of uncertainty just legally. I shouldn't be saying this of all the people on the panel, but it will be interesting to watch literally like what happens to this authority down the road, not just what happens to the potentially most important MFN policy.
The other thing that's going on that has less of an effect on Medicare specifically is Trump RX, which I just saw on Twitter is supposed to be revealed this Friday. So that's really something that'll be helpful to could be helpful to people who are uninsured if they can afford whatever medications are on Trump RX, but less of a Medicare interaction as far as I understand it.
I like the keep people late strategy, but I wonder if they had the hot cocoa bar, if we could have gotten somewhat lower prices. I'm going to ask a few kind of prognosticating questions from the audience about Medicare Advantage. I'm going to try to summarize 3 of them, and you guys can jump in or not. The one question is, are we actually going to see that sub 1% increase, or is it going to be revised up? The second is, if Medicare Advantage is appealing to healthier beneficiaries, as the baby boomers age, do we expect sort of a reversal? And the third is, do we think that the response to the MA squeezing is actually going to kind of trickle down to the ACOs, and we're going to see those providers squeezed?
One thing maybe on the healthier individuals, one of the key things is that when we say they have advantageous selection, generally what we mean is that if there are 2 people who look observably identical, they're both diabetics at the same age, with the same BMI and so on, the one that expects to have higher spending tends to go into traditional Medicare, and the one that has lower goes into MA. I expect that phenomenon is going to continue because MA constrains care more than TM does. So I don't know that that's going to like fundamentally shift over time.
And we don't know whether that's a pull because MA plans are marketing for healthier people,
Yeah.
or whether people are saying, you know, I'm scared, I'm sick, I want to choose my own doctor, I'm not going to MA. But yeah, we did a study several years ago where we had people who looked the same in traditional Medicare, but the person who consumed a lot of services stayed in traditional Medicare, whereas the other person who looked just alike but didn't consume a lot of services went into MA. On your first question about whether or not we think the 1% will grow between now and the final notice, I'm going to say I obviously have no idea, but if past is prologue, it seems quite possible given the political pressure and the lobbying that will be brought to bear.
And I would say it's also, you usually tend to see a higher fee-for-service growth rate, which is one of the components of the MA rate notice. You tend to see that higher when they finalize it in April than when you get the proposed in January, because it will likely incorporate later data from 2025 spend. So that incorporation of additional data and other factors often mean that when you get to the final, you see a different growth rate. So that wouldn't necessarily just be a political factor, but may also be just an inputs factor.
I'll say 2%. I'll put my flag in.
All right, should we do a bet?
Yeah.
Well, the betting market will be outside. We hear a lot about Medicare Advantage and how Disney World has the Medicare Advantage Pavilion. I don't know if you've ever been there, right? The insurance companies are very much in the Medicare Advantage business. But they're also in the Medigap business, right? Providing these wraparound plans. And I know KFF did a paper like 12 years ago that I still cite all the time about what that means for people's premiums versus their out-of-pocket costs. To what extent are these Medigap plans either pushing up overall costs and pushing up costs for beneficiaries, I guess, as well as the federal government?
First I would say that Medigap plus traditional Medicare probably offers the best financial protection because it fills in all the gaps, right? Or can fill in the gaps depending on what policy people choose. Economists who have looked at this have said that when people are not exposed to cost sharing, they use more services. So there's been evidence that Medigap plus traditional Medicare has the effect of increasing Medicare spending, if that's kind of the point you wanted to make there. It is really probably the best coverage people can get if they can afford it.
Meaning the most comprehensive coverage in terms of cost sharing, limited
Yeah,
cost
I
sharing.
mean, you don't get the most of the extra benefits, but you do have the financial protection, and in fact, it sort of eases the pain of traditional Medicare not having an out-of-pocket limit. Traditional Medicare is maybe the only health insurance plan without an out-of-pocket limit, and so it provides the financial protection that people need. But while we're on Medigap, a lot of people can't buy Medigap if they want to leave Medicare Advantage if they have a pre-existing condition, because in most states there aren't guarantee issue protections. And I can't tell you how many people don't know that basic fact, but it's really important for people as they're making decisions.
Our first speaker talked a lot about fraud in the overall system. Obviously, if we could solve Medicare by cutting fraud, that seems more politically appealing than solving it by all the things that I think are great, but you guys say are going to have some political challenges. Like, where's the fraud and where's the abuse in the system? Where are the opportunities, and where should we be investing more? Where should we be doing less?
Well, Miami, I think we said earlier, is geographically. I don't know. I believe that there's meaningful fraud in sort of any program this size. I generally, after sort of seeing these conversations and the data for a long time, I get the sense that there's way more money in gray area, low value, kind of unchecked spending than there is in explicit fraud. Maybe that's wrong, and I'd be very happy to learn that that's wrong in some sense, because that'd be easier. But to me, that seems like the sort of uncomfortable or frustrating answer.
Should we do a trip to Miami just to check it out?
Absolutely.
Send
And then
Oz there.
Las Vegas, apparently.
Yeah. Those sound like warmer places, but it's waste, fraud, and abuse, right? And I think Kim would talk about all of them as within the purview. And again, it's an area where I think there's a lot of hope that technology will enable smoother opportunities to identify these things real time. Kim made me laugh because when I was at CMS, we used to talk about the fraud prevention system as exactly like catching credit card fraud, right, where you'd get a ping. But I think her point about the lag between when care is occurring and when that claim is hitting, and the fact that even if you are doing a prepayment investigation in fee-for-service Medicare, it may be very long after the care was consumed. So if their vision includes pinging a beneficiary's phone when a lab test gets submitted 9 months after they went to an urgent care and got a swab, that beneficiary is going to be confused and have no recollection of that. So that's not a very good system. But if it's, did you go to this urgent care and get a swab yesterday, that's much more reliable and probably much less of a frustration to that beneficiary. So I think the technology opportunities that CMS is working to enable could help answer that where's the fraud question. But also, the coverage rules are also part of the where's the waste, and then I think what you're talking about is that abuse category of should we provide the care just because we could.
I mean, I was really excited to hear what Kim was saying. I mean, it sounds like using technology to go after fraud, and like, who could be against that? We were joking before when Marc was asking, like, well, what's your view about, going after fraud? Like, I'm all for it, and I really am. But I also caution us as we're going after fraud, because you don't want to waste taxpayer dollars. That's not going to fix the trust fund issue. That's not going to address the broader issues and big challenges that are facing Medicare. So it's kind of a yes, and more needs to be done.
Well, I think that's the perfect place to end, because I don't want to be between these folks and the snacks, which will be out in the hall. Please, when I dismiss you, go out there in an orderly fashion. There's going to be food and drink, and then please be back here in 15 minutes. But join me in thanking our panel for a great discussion on Medicare.
So I just wanted to start by saying, why are we talking about commercial pricing and the cost of healthcare overall? We're the committee for the responsible federal budget, So it's a little weird that we're talking about things that don't necessarily impact the federal government immediately. But overall, national health expenditures in the commercial sector are about $1.6 trillion, so it affects everything in our economy. And employer-sponsored health insurance, as I mentioned before, when people are paying their premiums, both the employer side and the individual side, those are dollars that are not paid in wages and that are not taxed. Okay, so and then there's also subsidies for the Affordable Care Act. These are tax subsidies. So the cost of private health insurance is incredibly vital to our federal budget. Okay, let's just get started. I'm going to introduce our panelists, and we're not going to have opening statements, and we'll just dive right in. Dr. Jibai is a professor of accounting at Johns Hopkins Carey Business School and professor of health policy management at Johns Hopkins Bloomberg School of Public Health. Patricia Kelmar is senior director of healthcare campaigns at US Public Interest Research Group. I always want to just say PIRG. Randy Pate is the founder and CEO of Randall Pate Advisors and former director of CMS's Center for Consumer Information and Insurance Oversight, Society to its Friends. And Dr. Chris Whaley is associate director of the Center for Advancing Health Policy through Research at Brown University. Okay, so what I wanted to start off talking about is ACA subsidies. And before we get into, pricing of healthcare, I wanted to just reflect a little bit on the negotiations and the debates that we were having all through the fall, all into January. It's probably not over. Many of us in this room have worked on these issues. We at the committee spent a lot of time on the Hill and talking to people. I was surprised at the dearth of conversation around modifying the subsidy schedule, right? Like there was a number of plans out there that were saying like, well, maybe we cut off the top, the highest income level, like 700% of the federal poverty line, but there wasn't a lot of conversation. It felt very black and white. Either we reauthorize or we don't, rather than let's take a measured look at the subsidy schedule and figure out, like, is there a better way to do this? Is there a fairer way? Is there a way that we can modify or reduce costs in a way that's just? Randy, what do you think about that?
I think it's a great question, and it's a very complex political topic. I think it's very difficult for the parties to come together on an agreement with anything having to do with the ACA, but particularly when you're talking about touching the subsidies. Obviously, during the initial years of the Biden administration, they passed the Inflation Reduction Act and created what we were told were temporary subsidies coming out of the pandemic, the enhanced subsidies that removed the cap for people over 400% of federal poverty, but also greatly increased the value of the subsidy for the people at the very low end. And those are expired now, and that's obviously been a big topic of debate. But even without the enhanced subsidies, I would say the subsidy structure is problematic in a lot of ways. One clear reason is without the enhanced subsidies, you had this cliff at 400% of federal poverty. And so people who were early retirees looking for a bridge to Medicare, or higher income people who were self-employed, they were facing ridiculous premiums in a lot of areas of the country. So there's that issue. And then also the way the subsidy is structured, it's based on the second lowest price silver plan in your area, wherever you live. And as long as you are responsible up to a percentage of your income and premium, so say 8.5% is sort of the cap, and it goes down from there based on income. Above that, the federal government is picking up 100% of the tab. So that causes inflation, both in the premiums, which there's just not a lot of cost containment, in that subsidy structure, and in the overall healthcare costs. It all sort of drives things all together. So I was really disappointed that we didn't have a more robust conversation, or we're not having it, around the subsidy structure and what could be done to address those two issues. What happens to the unsubsidized people who are facing the high premiums, and also addressing the inflationary impact of the subsidies.
And I just want to remind our panelists that you are free to jump in whenever you feel like it. G, I wonder if you might have something to comment. I know I've read some of your work and I've seen some of your various comments about letting the subsidies expire.
Yeah. I believe the essence of this issue is ACA created this unaffordability problem through many channels, including consolidation. Look at the insurance market, hospital market, same thing happens. So the price becomes more expensive. More specifically, premium becomes more expensive. That is the fundamental unaffordability. Then they use subsidy to create a fake affordability. So this whole conversation, we are not addressing the fundamental unaffordability, just saying, okay, let's put more Band-Aid on the surface, keep creating this mirage, this dream of affordability. So I think this is really consumer deception and taxpayer fraud.
I wonder if, can you say more about in what way the Affordable Care Act actually drove consolidation? I mean, we all know that consolidation is a huge driver of some of the markets out there that are less competitive than we might wish. What was it about the Affordable Care Act that motivates consolidation?
If I would just kind of started, look at MR, medical loss ratio. If you're a small insurance company, you cannot survive in a medical loss ratio situation. If you are an insurance company, want to provide or innovate and create some kind of cheaper new plans, you're not going to meet MR, medical loss ratio, right? So this is just one example how the ACA kills the affordable plans and makes the market more consolidated. So it's not intentional, right? But as a result, our market becomes more consolidated. So that's just, yeah.
Chris, you've done a lot of work on consolidation.
So I agree with G's point that the medical loss ratio, which is basically the requirement that a carrier has to send out a certain portion of its claims expenses and can only keep about 15% in terms of its own operations and profits, doesn't make a lot of sense because 15% of a bigger pie is a bigger amount, and so that leads you to either go out and try to acquire other insurers, or what we've seen, I disagree that this is entirely due to the ACA, and this has been kind of a longer standing feature of the healthcare system. Go out and say acquire a physician practice, and if you say pay that physician practice a little extra, then that's revenue, but then you're kind of double dipping because that revenue that you're paying out is actually revenue that's going back to the mothership. And so I think that's a pretty key reason why, at least to its investors, United Healthcare says that they either employ or directly manage about 10% of all physicians in the United States to essentially play that bit of accounting shell game. But I do think that the overall effect of the ACA is one component on consolidation, but there are numerous other factors, whether it's hospitals going out and acquiring other hospitals, which is a trend that goes back to the late 90s, or we've seen more recently the rise of private equity. And all these features have really changed U.S. healthcare markets. And it's really hard, I think, to think about another industry in which we collectively spend about $5 trillion, where we have such consolidated markets and consumers have such access to competitive markets and providers.
Mm-hmm. So more competitive markets might be one way that we could reduce costs in the ACA marketplace. What are some other ways? Patricia, do you have any thoughts?
Well, I think, my biggest frustration in this whole debate over the last few months is we weren't really talking about prices, right? How much it's costing us. If prices weren't so high, premiums wouldn't have to be so high. People's individual responsibility of their co-pays and co-insurance and their deductibles wouldn't have to be so high. Consolidation has definitely impacted people's ability to be able to seek lower cost care. If you remember when the first, ambulatory surgery centers started to come about, we were all very excited as a consumer organization, right? Finally, there's some competition for the kinds of surgery that don't actually have to happen with an overnight stay and all the bells and whistles of a full-on hospital. We can take some of these surgeries, bring them to a less expensive center, they're newer, they're cleaner, and they're more efficient. And it was great for patients, right? Many times they were in their own communities, there was good parking, they didn't have to drive downtown, and they got to go home and sleep in their bed that night. Well, that brought a lot of profitability out of the hospitals. What did hospitals do? They're like, we're in on this game. Hospital outpatient departments started popping up in all these communities, across the street from the ASCs. And so now when we're seeing that this kind of vertical consolidation where our doctor is referring us not to an ASC, they're referring us to the hospital outpatient department for our procedure. The hospital outpatient department is billing like a hospital, using that billing identifier and billing like a hospital. Those cost savings are gone. And it's just driving up our prices.
May I follow up on this? Of course. So ACA has two provisions related to what Patricia just mentioned. The first is 340B. ACA substantially expanded the 340B program. That give hospitals the upper hand, right? Because they can make money from the 340B program, but the individual physicians cannot. So that motivates hospitals to consolidate, vertical consolidate, to buy physician practices. That's why we're seeing independent physicians dying. Second provision, banning physician-owned hospitals. The grandfather in, you're fine. You cannot start to expand physician-owned hospitals. Why? That's a horse trading, right? Political horse trading to gain the support from AHA. As a result, the physician-owned hospitals cannot compete with existing hospitals. Did you see the AEI's updated figure, like past several decades, what the price changed? Cars, TVs, hospital, whatever. You can see the hospital price, like, the most dramatic increase is for many reasons, including the provisions in ACA.
Okay, let me make sure I'm understanding. So, I hear there's consolidation vertically between insurance companies purchasing providers, and then there's also consolidation vertically among, hospitals purchasing outpatient departments, ASCs, what have you. So if we have these big companies or, nonprofits, shouldn't they be battling it out and having lower prices? Aren't they, now they're equal, they're both super consolidated. Why isn't that happening?
Well, in most communities, there's only one hospital system, or maybe two, right? And there's our insurers trying to negotiate some price, right? But they need to be able to make sure there's network adequacy, so there's demands on that, right? And so if all of the oncologists are owned by a hospital system, they have to put that oncology practice in their system. They can't find that independent one and negotiate and try to get a better deal. But we can see what happens when the insurers or the employers can get access to the claims data and the information. We saw what happened in New York, right? 32BJ, it's a union. It really drilled down on its claims, and it said, this hospital, I think it was New York Presbyterian, but I could be wrong, is so much more expensive. We're just cutting it out. And they had to spend time explaining it to the employees, right? Because people did want to use that hospital. We're going to be able to get you better wages because we're going to be able to bring down the cost of our health insurance, and you are going to get as good care. They looked at data that they could find. We need more good quality data. But we need to combine the cost and the quality and give that information to the people who are designing our plans so that we can, in the places where there is choice and we can drop some of the providers, we can negotiate better deals. So it's prices, basically, it's transparency, it's data, but we also are bumping against the lack of choice in many, many communities, right? New York City is different, but if you live in small town America, you have one system. If you live in, Western Pennsylvania, you got two big systems fighting each other.
Randy?
I was just going to add, Patricia, to your point about the hospital lack of competition. From an insurance company perspective, and I'm just thinking about the Affordable Care Act network adequacy provisions, which have changed now to include time and distance standards, appointment wait times, and so on. You have situations now where you have all or nothing contracts from the hospitals that basically say if you want to contract with our rural hospital, you have to contract with every other hospital in our network. And if you look, for example, I've seen maps of Metro Atlanta where it used to be that you could have 1 or 2 hospitals in a county, and that met the requirement. Now, because of these expanded requirements, they basically have to contract with every hospital system in the county just to meet the network adequacy requirements. So there's not, how are you going to drive lower prices in that type of environment? It's impossible.
Chris, G brought up hospitals and pricing. I know you've done a lot of work in this area. What does the research tell us about hospitals' ability to command prices?
Yeah, so I guess a bit of a history lesson. So it used to be that hospital markets were actually fairly competitive. In the late mid-90s, managed care came into effect, and insurers really started pushing against hospitals, and that led hospitals to consolidate and insurers to consolidate. And since about 2000, there's been about 2,000 hospital mergers in the United States. That's about 2/3 of all hospitals in the United States have been some part of a consolidation event. And that chart that G was pointing to, if you look back what happened to prices, commercial and Medicare prices generally tracked for many years. But in 2000, once hospitals started merging, there's been a huge uptick in hospital prices. And so if you look anywhere across the economy, hospital prices over the last 2 decades have been the area where prices have increased the most. And so the big question is, what can we do about that? Could we go back and unwind all this consolidation and go back to the level of competition where we were in 2000? I mean, if you look at the Federal Trade Commission or Department of Justice guidelines, 90% of U.S. hospital markets exceed what the FTC or DOJ would say is an extremely concentrated market in evidence of monopoly behavior. We probably can't do that. That's probably not realistic. And so what some purchasers and groups, as well as many states have done, is said, we're not going to unwind all this consolidation realistically. And so maybe we need to think about regulating some of the adverse consequences of consolidation. So if you're a big hospital or a big provider, that gives you an incredible amount of price negotiation leverage. And so maybe we need to limit some of that negotiation leverage. And so, for example, the state of Montana and the state of Oregon, for their public employees, it said, we're just going to pay 200% of what Medicare pays. Medicare is roughly the break-even rate, and so that's break-even plus a whole 100 extra percent. And so that's, I think, a fairly healthy margin. And then more recently, Vermont, so we just heard from Senator Welch, as well as Indiana, so 2 very, very different states, have said, we're going to implement the same policy across the entire commercially insured population. So I think that these 2 policies are areas where there could be substantial savings. We've modeled that in the state of Indiana, there could be about $1 billion in healthcare savings for individuals in Indiana. And likewise, we've shown that the state of Oregon, for their public employees, saved about $100 million. We've done some work with the committee showing that if the federal employees' health benefits system, which spends about $75 billion per year, were to do something similar, that could save about $90 billion over 10 years. And so I think that these types of policies are ones that if we're thinking about affordability and acknowledging that prices, particularly on the hospital side, are what are challenging healthcare affordability, that there's a lot of policy momentum in trying to address.
Great plug. I love that. Checks in the mail. Okay, so hospitals for sure have always been, have always been on the hook for driving costs. Insurance companies, managing costs is their job. That's what they're for. If we didn't have insurance companies, we can talk about that. But insurance companies, they're supposed to have prior authorization. They're supposed to manage the care that people are getting. They're supposed to negotiate prices with these various providers. They should be able to reduce the premiums and the cost sharing that consumers pay. G, you brought up MLR. We have various mechanisms. Maybe you can explain what MLR is, as well as how it compares to risk corridors or whatnot. We have various mechanisms to address insurance companies, but why aren't insurance companies doing a better job of controlling prices?
Well, it's because the regulations make them increase the premiums. So if you are an insurance company, you have this big pie of medical premium, how much revenue you get, right? And the law says you can only take a slice. The slice is determined. So how can you make more money? Make the pie bigger. That's the only way, right? Without regulation, what you can do? You can make the same pie, but you can have a bigger cut, right? So that is how MRR promotes insurance companies to increase spending. Have you heard the October rush? So if you're an insurance company, October, you're looking at your total spending, you realize, my God, total spending too low. And then you have to relax the prioritization, utilization control. Let people use X-ray, let people use MRI when they can use X-ray. So to jack up your total medical spending. So then next year, your premium will be high. If you are insurance company CEO, the worst news you heard is that next year the premium will be low. Because that means your revenue is going to be lower, right? So that's how the regulatory environment basically prevents insurance companies from doing the right thing for consumers.
Now, Randy, you were the regulator, so I feel like you should weigh in here on this.
Absolutely. I mean, the MLR, I'm not a huge fan of MLR in part for that reason, and actually co-authored a paper with G over the summer kind of pointing that out. But, I would say there are a lot of factors that increase costs and make it harder for insurance companies to drive lower rates, and that's one of them. We talked about network adequacy rules, we talked about, there are prompt pay laws, there are restrictions on pre-auth, all of these things that are supposed to be cost control tools are blunted often in some way. So, I think they're being asked to do something that's almost impossible in the regulatory environment. So we shouldn't be surprised that they're not doing a very good job.
May I add real quick? ACA removed the lifetime or annual maximum limit. Before ACA, there might be a 1 million limit. If you spend more than $1 million a year, you can't, the insurance company not going to reimburse, right? But ACA says no more cap. What happened is after ACA, those multi-million-dollar claims ballooned. Because how can you, as an insurance company, to stop people, right? Because you have to cover, there's no limit. So you're basically tying insurance companies' hands, saying you guys cannot do the spending control. And then guess what? The providers, the hospitals, the drug companies look at this, well, the insurance company cannot do anything about it. So let's just give the very high price to the procedures, the drugs, then everybody pay a higher premium. That is how it happens.
If I can jump in, just from the consumer perspective, look, we have a system that we are paying so much money for, both as our employers, as our federal government supporting, rural hospitals and, using bump up payments to help our hospitals stay open. And yet it just doesn't work for people, right? So I get calls and we've been talking to people about price transparency and, they're just so afraid of what the bill is going to be at the end of the day, right? They bought their insurance, they have their insurance card, they're calling to see what is that colonoscopy gonna cost me out of pocket? Nobody can tell them. Their insurer can't tell them, the hospital can't tell them, the doctor certainly has no idea. They, throw up their hands and say, well, that's not my thing. You'll have to talk to the clerk down the hall, right? And so this is a thing that's really frustrating from the consumer perspective. We are paying a lot of money thinking that all these people are getting this great care and have access to the doctors and the preventive screenings, but people are canceling those screenings. They're canceling further appointments and follow-ups because they're getting a facility fee from the hospital. Unbeknownst to them, their doctor now is owned by a hospital system, and they get a $2,000 facility fee to visit their oncologist for their 6-month checkup, right? Mm-hmm. So these are the things that are hitting us, and so just opting out seems like a better option when money is tight. Mm-hmm. And that's not what our insurer wants. When you think about the federal budget, right? We're trying to keep these people in the commercial market healthier, like we think we're doing. We're getting everybody's insurance. They're supposed to get screenings for free and not pay for all of this. But the people I'm talking to, they're not going to the doctor because they're so afraid.
This leads into a whole separate type of conversation I wanted to raise as well. So good segue into, there's been so much discussion all fall and for decades about price transparency. If people knew what they were going to pay in advance, They would shop around, they would identify the lowest cost provider, and then they would patronize that provider and just, like it would be like any other market, and prices would come down. Maybe, Patricia, maybe you can start. Talk about how price transparency has promise for reducing commercial prices and maybe where the limitations are as you see them.
Yeah, so there's two things about price transparency. First of all, on the front end, for the things that you can schedule and where you might have choice in your community, wouldn't it be great to be able to look and just see what is that MRI going to cost if I go over here or over here? And our hospitals are supposed to be posting that and giving that information. Usually if you call an imaging center, they're a little bit better about telling you what the actual cost is. But so that's the first thing, right? So where there's choice and where you can plan, you would want to be able to look around. And the better these tools get, the easier it will be. And our employers even could be helping us with that, right? Like steering us to this. And we know that there are some employer plans that are like giving you a bonus or a gift card if you go get all of your blood work done at this lab place. The other end, and the more important part of price transparency from the consumer perspective, is the fact that when we get a bill, we just get a bill. Like, it seems incredibly expensive. It seems like we shouldn't have to pay this, but we have nothing to compare it to. Is it right? Is it wrong? Should I be paying all these fees? We get calls about these facility fees. They're like, is that legit? Like, is that something I'm supposed to pay? So, the health literacy of medical bills it's basically nothing, and that's because every medical bill is different. We've got codes, we've got language no one understands. And so having that price transparency on the back end could also be helpful for people like, wait, I thought that wasn't going to cost that much. Let me go look it up. Let me see what that CPT code is, and let me see what it was. So.
Yeah, I think we can all agree that more clarity would be amazing. I mean, I'm sure we've all had the experience. We're all in this health policy professional world and have gotten bills that are just baffling or surprise bills that we didn't expect not to, we'll talk about nose prices, but not that. But Chris, you've done a lot of work on some of the limitations, like where does price transparency and informing consumers about their ability to choose their provider, where do those limits come into play?
So I guess an audience question. So if you have commercial insurance, I am almost certain that for the last 10 years, you have had access to some sort of price transparency tool. But how many people have actually logged in and looked up a price for a service before they got something? So I've done that, and I see maybe like 7 or 8 people. And so I think that the healthcare system, at least right now, just isn't really set up for price shopping. A lot of that is that you're a patient, you didn't go to medical school. It's really hard to say, do I need a procedure or another procedure? As Patricia said, having one price, but not knowing whether that's a fair price or even if the service is required is just a huge barrier. And so we have seen, I think, a lot of entrepreneurial activity in increasing the hands in the room and getting people to actually use prices. But where I think there's actually maybe been a little bit more push is being upstream of patients. So if you're an employer, a key part of your job is essentially to provide and to purchase health insurance on behalf of your workforce and their families. Most employers are doing that totally blind, and a lot of the conflicts of interest and structural differences that G mentioned, I think are even more so in the employer-sponsored insurance market. And so where I think price transparency could actually be very, very helpful is to inform employers and purchasers of those decisions. So the 32BJ example that Patricia mentioned, that was entirely because the 32BJ union had price transparency data, saw that New York Presbyterian was charging prices of about 400% of Medicare, and there are other high-quality hospitals that are much less expensive, and made a business decision to shift patients away from New York Presbyterian and saved enough money to give everyone in their union a $3,000 one-time bonus. And so I think that's kind of the key kind of nexus of where price transparency might be a little bit more fruitful.
I want to pursue that a little bit. I've thought for years, where are employers in this conversation? Like, why aren't employers, feeling super, empowered? They have every reason in the world to want to minimize prices for their employees. They have so much skin in the game. Okay, well, why aren't they doing a better job? I mean, we have wasn't Jamie Dimon or something, they formed a group and they're gonna work on it. There have been so many efforts over time that have not come to fruition, that have not succeeded in lowering prices on a large scale. Chris, it looks like you were already ready to.
If I were to exact same question, raise your hands. If you've complained to your HR leader that my premiums are too high, and why do you have certain hospitals in network versus other hospitals, I don't think anyone would raise their hand. I've made that complaint, but maybe that's unique. And so that's the real issue, that employer, if you're an employer, your job is to run a business. And if your workforce essentially is not complaining about network design and prices and all that stuff, why go through the effort? And if it's coming out of the wages, and if workers are, by not complaining, revealing they are fine getting paid in healthcare dollars than take-home dollars, then many employers will say that's not our decision to make.
So I'm trying to change that trajectory, Chris.
Yeah, I mean, I think that's not right. I think employers should be. I think everyone should complain to their HR leaders about prices.
With surprise billing, I would get calls, and especially now we have ground ambulance surprise billing is, we have no protections except for 24 states that are, have limited protections for people in state regulated plans. But, I get calls all the time about these huge ambulance bills. And the first thing I say is, you as one person with one ambulance bill, it's really going to be hard to convince that, especially private equity-backed ambulance company, that you don't have to pay it. But go to your HR department, because this is the local community employer. If that ambulance is out of network for your local employer's insurance, then your HR department should know that, and they should talk to the city council and ask whether or not they should contract with that 911 service provider in the future, right? But that's a level of organizing we have to do. I don't know how much you know about PIRG, but we're a consumer-based organization. We're knocking on doors, talking to people about these kinds of issues. People join us. They hear about these issues from emails we send them. And this is really, this is a serious invitation. I invite any of you who is interested to have a conversation. Join me on a call with any of the patients who talk to us and call us, because it's really important to just spend a second talking to people who are going through these billing problems. And find me afterwards. I'll be probably by the bar, but give me your card. Let's get you on the phone. Just listen to what people are experiencing day to day with their bills. It's incomprehensible. They can't understand why they don't have the coverage. They don't know how to fight it. And the debt collector is right at their door expecting that $3,000 bill to be paid in 90 days.
Mm-hmm. I think we've all experienced frustrating bills at one time or another. Yeah. I wanted to come back to you and price transparency, because I know you've done a lot of work in this area. Where do you see price transparency for consumers being useful in reducing prices? Is that a model that can actually succeed, to really take a chunk out of what we're all facing?
Thank you so much. Well, I think we have to make a clear distinction between voluntary price transparency and mandatory price transparency. So right now we are trying to do mandatory, right? The government says you have to disclose this, and you do it. Why? In compliance, right? You want to do it to comply with regulation. Then guess what? Hospitals buried somewhere, not patient-friendly at all, right? And then this actually increase the administrative burden for hospitals and would not make a huge difference. Do you agree, right? Mm-hmm. But then voluntary transparency is you want to do it because by doing so, you gain business. This happens everywhere when we have patients control their dollars. Think about plastic surgery. Plastic surgery, and any website you check, the price is transparent. Go to the surgical centers serving cash pay patients. They have the pictures with the price all bundled together, making patient life extremely easy. By the way, without any government regulation. Again, if this will help, price transparency will help business gain their revenue, they will do it. Right now, we don't have that. Mm-hmm. Imagine tomorrow, everybody controls their own healthcare dollars. Everybody controls it. Then if you pay $1 more, it's $1 less left in your pocket. Things will totally change. Hospitals, providers, everybody will immediately disclose without any government mandate.
But gee, half of people in the country with insurance are on a high deductible plan.
But then what happened after they meet the deductible? Well, I do not care about price at all once I meet deductible.
If we look at people in deductibles, regardless of whether they're on the deductible phase or regardless of their health savings account, and we look at their price shopping behavior, we don't find any difference.
Yeah, I like Chris' point. But if you are thinking from a hospital perspective, more than half of the patients are already on Medicare, Medicaid. They do not care, right? In essence. And then you have a lot of patients already meet deductible. We have heard, like, if you think myself, like say myself, after I meet my deductible, why should I care about the price at all? No, I won't. And so that's why we have a very small portion of patients, consumer market, that actually care about price. So that's why, I'm with President Trump's call, like, let patients control their money. I think that's the only way.
I think part of it is we just don't know what a right price is, right?
Well,
so we've gotten so far away from like cost plus for what a price is because it's been so non-transparent, right? We don't really know the price, so we can't today, go out and get anybody to tell us what that colonoscopy costs.
But remember, the cost is fluid. If you look at any other industry,
It's not.
How do they do that? They have to reduce price to gain business, right? So everything try to undercut each other. So how do they do that? They have to use technology to reduce the cost so they can get market share. So the price is a result of the technology, cost reduction, and the need to gain market share. So that's how it works. So there's no such a, okay, this is the right cost, this is the right price. No, it will change all the time, change constantly, like in any other industry.
I think one of my favorite studies that I've done is Safeway, the grocery chain, about a decade or so, gave their patients a very high-powered price transparency tool for things like lab tests and imaging tests. And everyone here, these are checkout clerks, very high deductibles. They gave the tool. Nothing happened. No price shopping, no change in behavior, nothing. And then they, a year or two later, said, we're going to pair this with a financial incentive that if you don't go to hospital, so we talked earlier about site neutral in the last session, that also applies to commercial markets. If you go to a non-hospital setting, we're just going to waive cost sharing. And lab imaging tests fell by 20%, or the prices. And so I think the way I think of price transparency is a necessary but not sufficient condition if we were trying to have a better healthcare system. And we need to have data on prices. We need to have both consumer, researcher, and regulator access to price transparency. But if we just have that data by itself, it's not really going to move the needle because that data has been out there, again, for a decade, and 8 people in this room have actually used that data.
Yeah, I guess I would just make the point, though, that in what other market or context do we tolerate not having the price before we go in for the service? When you go on an airplane, they don't say, hey, we'll tell you how much the fare is when you land, right? And that's basically what we're doing as a country. And I mean, I think there has to be price transparency. There has to be quality data. We have to get it in people's hands. Obviously, we've had a lot of years down this road where we've got the third-party payer ingrained, employer system mindset ingrained. And I think the employers, Chris, to your point, are critical in this. But I really believe the consumer side of this needs to be right there with it.
Does anybody want to comment on the administration? I think Trump one implemented hospital price transparency regulations that required hospitals to issue all kinds of data. And how did that go? And how is that? How could that be improved?
Yeah, I mean, so I helped to draft the transparency and coverage regs, which were on the payer side. So it included ERISA plans, it included large group, fully insured, small group, individual. And so that was a very big effort too, the hospital side. But what we noticed is as the law was, or the regulation was being implemented, bipartisan, by the way, the Biden administration, implemented the rules. We were seeing zombie codes or garbage data being put up there. We were seeing the websites where you're supposed to go click and find out what the costs are being sort of buried in different places everywhere, depending on the hospital or the payer. We were seeing, situations where entire chunks of data were just missing or completely inaccurate, right? So there wasn't a lot of enforcement. There was very little enforcement of the mandatory price transparency provisions. I think enforcement should be increased. I think states should step up, and some of them are with their own price transparency laws. I think we have a long way to go on that. There's been a new proposed rule on transparency and coverage that was just released right before the holidays. So the movement is continuing to happen. I think it's bipartisan. There bipartisan legislation to sort of codify the Trump rules on price transparency. So I hope it continues.
I think the data is foundational. And again, if we are to have a better and more transparent healthcare system, this is the type of data we need. It's not perfect, and it's an iterative process to improve the quality and the types of data and the reporting and all that. But I think it's incredibly important that we have this type of data.
We have a working paper showing that in the past 5 years, after price transparency rule came into effect, the price actually dropped if you adjust for inflation. So it's a working paper. Thank you.
Excellent.
So I think the missing thing, though, with the price, right, is also the quality, right? Like, ultimately, people just want to get better, right? So we haven't done a great job with quality, transparency, and as consolidation is happening, we're losing a lot of that brick and mortar individual information about patient safety and about infections, right? Some of that data is now being reported as a system, right? And we all know, like, there are lousy hospitals in a system and there are great hospitals in a system. And there's actually great floors that are preventing infection in the hospital, and some floors where nobody's washing their hands and the nurses are overstaffed and overworked, and right. So we just aren't at a point yet where we can really like confidently trust that price is the right way to choose, or my neighbor loves her cardiologist, so I should just go, right? Like, what a crazy
Or
way.
your doctor referred you.
Yeah, like, why are we, how can we still be here with all the data that we know, with clinical, data that we could really crunch and know that people are better, and we're not holding anyone accountable to all these dollars that are being spent to know that the outcomes are great, right? We want great outcomes. Forget the price, forget like the brand name, just like, am I gonna get better under your care?
We can't forget the price because we're the federal.
I know, but
Yeah.
value is also part
Yes.
of having a budget, right? We want people healthier, longer, and nip that thing in the bud, not let them get the infection that makes them stay another 10 days,
Yeah.
right?
Okay, so we've talked about a whole range of things, and I want to make sure we really talk about solutions. What can we do? Like, again, we got the smartest people in the world here. Like, let's give everyone a lot of our best ideas that we can all carry forward. We've talked about consolidation and competition, price transparency. We've talked about role of employers, role of unions, role of individuals, role of regulators, insurance companies. What are some of the solutions you see in order to bring down prices in the commercial sector? Who would like to start?
All right.
Chris, you lean forward. Oh, okay.
The cop-out answer is that Nixon in the 70s said, if we don't do anything about healthcare spending in the United States, it's going to totally destroy the country. When we were at, healthcare is 7 or 8% of GDP, and so the easiest answer is, well, we'll just have the same conference, 5 years from now, and instead of being at 18%, we'll be at 21%. We've got to spend money somewhere. We might as well spend it on healthcare. But if we're actually going to do something, if our goal and kind of thought process is around budgets, then I do think what's happening at the state level around reference-based pricing is actually quite encouraging. And this, at least in my view, has been the one thing that actually has moved the needle on spending and has substantially reduced state level spending across several different settings, several different population groups, and something that could be successful. So we've got another study showing that if we were to apply reference-based pricing to broader commercial markets, we'd basically move the U.S. down from where we are now in terms of leading OECD, down to roughly Switzerland levels of healthcare. So substantially low, still high, but quite a bit lower from where we are now.
Wow. Switzerland level of price.
Switzerland level.
It sounds amazing. Okay.
So I'm coming from the individual market and sort of ACA perspective on the payer side, but I really like the idea of looking to the states, especially now that we're sort of post what's going to happen with the enhanced subsidies. So I'll throw out a couple of ideas. One is what we've been talking about, which is sort of an HSA or account-based subsidy. I really think states need to start looking seriously at doing some of that, whether it be through waivers or in partnership under existing law, along with price transparency. Another idea I think that's related to reference-based pricing is, there are a lot of situations where, health insurance may not be the best mechanism. For a high-cost enrollee, somebody who has a very expensive condition, and I'm not talking about a high-risk pool per se, but what I'm talking about is maybe looking at a separate type of mechanism. You see this happen in the self-insured side. Walmart's tried the sort of center of excellence approach, direct contracting for services, and cash pay, a mixture of that for some of the really high-cost folks, and or maybe for some of these very expensive therapies, some of the gene therapies, and so on, where you could pull those costs out of the system, and have you're going to lower the administrative costs significantly by just taking that out. Another idea would be direct primary care, as a layer in some of these states, individual markets, for example, where the preventive services are free anyway under the ACA. So why do they need to run claims? Why do you need to run it through insurance for a $150 visit every time somebody goes in for a vaccination, right? So maybe use direct primary care to take those costs out and contract for that directly.
So I would just say we've just talked a lot about hospital prices. So what we have to do is we have to eliminate those payment policies that allow hospitals to charge hospital level prices in our outpatient care, right? Like, we just need to get that primary care and those telehealth appointments and those outpatient appointments to be charged as if they are outpatient appointments as opposed to hospital-based care. So that would be the first thing, which is the site-neutral policy, eliminating facility fees. And then we didn't talk at all about drugs, but drug pricing is a huge issue, especially for consumers. It's really important for keeping people healthier, right? We need people to pick up those drugs that are going to keep them out of the hospital. That's an important thing. And so I really urge you, if you're not involved in looking at the issue of patent reform, that is everything. Consumers love generic drugs. Competition in the drug space really brings down prices up to 70% once you get 4 generics on the market. Like, this is where we could still make it happen, but we have a patent office that is thinking every little change in the dosing, in the instructions, in the delivery mechanism deserves its own patent that gives it another 20 years of exclusivity. So we just need to take a look at that and be smart about the patents that we're giving so we can get more competition. And then the other thing is we have this great new plan to negotiate for drugs for Medicare. Let's give everybody access to those negotiated prices. And we only have 10 drugs right now. We're bringing on another 20, right? Like, there's thousands of drugs that Medicare covers right now. So let's just really expand that Medicare negotiation for drugs.
Gee, if you'll permit me, I do want to stay on drugs for one moment, if you don't mind. We hear drugs all the time, talking about it all the time. This administration is very focused on reducing the cost of drugs. We've got a lot of talk about MFN. Oh my goodness, what does it stand for?
Most favored nation.
Most favored nation. Thank you. Okay, I'm so glad to be in a room with smart people. We've got most favored nation. We have Trump RX. Are any of these ideas likely to reduce the cost of drugs for consumers?
There's not enough information on most of them. It's very hidden. So for us to evaluate it, it's really hard, impossible to know. And then can't hold them accountable to agreements that are made behind closed doors.
I believe Trump RX, at least for Trump RX, is a reflection of what they are trying to get. That is to put the patients and the providers, including manufacturers, as close as possible. Get rid of middlemen as much as possible. So if they keep doing that, we're going to see actual effect.
Okay. I think the challenge with most favored nation policies, and this is emerging as a challenge in Europe as well, is just how it interplays with rebates. And so if we say we're going to pay no more than, say, what France pays for whatever drug, then manufacturers will go to France and say, look, France, we're going to charge you $1,000 for a drug, but we're going to have a confidential rebate of $500. So you're only paying net $500. And so if this leaks, then we'll charge you the full $1,000. But as long as you keep it secret, you're only paying $500. And so if that happens in the United States or with most favored nation policies that the United States pegs to, it would hard to see how there's going to be any difference in actual prices.
Okay, G, I skipped you. Let's come back, and again, solutions. We here are all about solutions. What would you say are your top solutions to reduce prices or to reduce spending in the commercial sector?
Thank you. I think for the past more than a century, we have been taking healthcare as a unique animal. It's different from anything else. So we use a lot of government intervention and pull the market as far as possible away from free market and distorting in many, many different ways. Now I think it's time for us to take a different path. Maybe we should take healthcare as one of many personal services and let the market follow economic principles. So what do I mean? First, free patients. Let the patients control more of their healthcare dollars. So patients can personally and directly benefit from better health and lower price. That will immediately instill dynamism in the market. That's number one. Number two, free providers. What do I mean? Let the providers compete on a level playing field. Right now, as I mentioned earlier, the physicians in the hospitals, AICs, are not competing on fair market with hospitals. So let them compete fairly, then we're going to see true competition. Number three, free insurance companies. Let insurance companies provide designs, plans that the patients actually need and want, not what the government believes is good. So if we do the three things and do some deregulation on the side, I believe we can achieve incredible innovation and affordability in a very short run.
I feel like we should have done opening statements. You guys were so good. But let's leave it there. Can everyone join me in thanking our panelists? That was so great. Thank you all so much for being here today. I mean, again, I just want to reiterate, we didn't know what to expect, and DC, you have really surpassed my expectations. Thank you so much for coming. Remember, we have hot food, hot drinks, and some cold drinks as well, and you have all earned it. So please join us at the reception at the back.
Let's give Anna.